persistent behind getting this study done, Elizabeth Cohen, and also Dr. Benny Jang, who was a co-principal investigator for the study. So why are we talking about varicella zoster virus? This is, of course, the virus that leads to in reactivation to shingles. This is a very common condition. We see over 1.2 million cases yearly in the United States, and of course it's more common with age, occurring in 1 of 2 patients estimated over the age of 85. And as ophthalmologists, 10 to 20% of these involve the trigeminal nerve, presenting with a classic rash and potential ocular findings, which can vary quite a bit, but there are a number of intersegment manifestations that we see routinely, as we were just hearing about in the last talk. And they can be more chronic as well. There are, of course, a lot of other posterior segment findings and really involving all aspects of the globe and surrounding structures that can be involved because of herpes zoster. Post-herpetic neuralgia is the most common complication of zoster, and this occurs in about 30% of patients with herpes zoster ophthalmicus, mostly after the age of 65. The standard treatment is defined primarily for use of antivirals in the first 10 days within the onset of the rash, especially if they're initiated within 72 hours of the onset of the rash. There are a number of adjuvant therapies that we use depending on which complications of what part of the globe or surrounding structures may be involved. Of course, we also have the recombinant vaccination, Shingrix, which is available in the US now. The live attenuated is very effective in treatment and is recommended for anybody who's immunocompromised over the age of 50 with receiving 2 doses. Herpes zoster ophthalmicus is also very common in terms of recurrence of disease, occurring in about over 20% of patients, where uveitis is usually the most typical presenting sign. There's also recurrence associated with even with use of topical steroids. And especially with multiple recurrent episodes, there can be significant vision loss and therefore morbidity associated with this for our patients. So the herpes zoster eye disease was set up as a double-masked, multi-center, randomized controlled trial for immunocompetent adults over the age of 18 with a history of a typical unilateral rash, and this episode being documented in the medical record within the year prior to enrollment of presentation with keratitis and iritis. Patients were randomized 1-to-1 ratio to suppressive valacyclovir 1,000 milligrams daily or placebo for 1 year of treatment with 18 months of follow-up with study visits every 3 months. There was also further stratification based on grouping of age and time of onset. So there was stratification for patients who were less than 60 and over 60, as well as more early onset within 6 months of the rash and more than 6 months of the rash. And the rationale for this was really based on the expectation that about 50% of the patients would be less than 60, and that there would be greater potential benefit in patients who had earlier onset or less than 6 months onset. 527 patients were enrolled and matched between the valacyclovir treatment and placebo. So when looking at lessons, it's helpful to look at what questions the zoster eye disease study was trying to answer. The first question was, does suppressive valacyclovir treatment, when compared to placebo, delay time to first occurrence of new or worsening ocular disease by 12 months? The ocular disease that this study was focused on were intersegment findings, including dendriform epithelial keratitis, stromal keratitis, endothelial keratitis, iritis, and stromal keratitis with ulceration. You can see the percentages of the findings that were observed in the study. About 1/3 of the patients had a occurrence of new and worsening disease. 2/3 of those were stromal keratitis, and 20% nearly were iritis. So the primary endpoint showed no significant treatment benefit at 12 months, but there was a significant benefit for the secondary endpoint at 18 months. And when looking at by stratification, there was no significant benefit noted with age, so age less than 60 or more than 60 did not result in an improvement of outcome with treatment. However, recent onset of herpes zoster ophthalmicus less than 6 months was significantly beneficial both at 12 and 18 months. Another important finding was that when looking at a lower risk of experiencing multiple episodes or recurrence, there was a benefit as well, observed both at 12 and 18 months. So lesson number 1, suppressive valacyclovir treatment of 1,000 milligrams daily for 1 year reduces new or worsening keratitis or iritis at 18 months in immunocompetent, non-pregnant adults with good renal function. Suppressive valacyclovir treatment also reduces multiple episodes of keratitis or iritis. The second question was, does suppressive valacyclovir treatment reduce the incidence, severity, duration of postherpetic neuralgia compared to placebo? In this study, at enrollment, 14% of participants had postherpetic neuralgia, and it was more common in patients who are more than 60. Overall, postherpetic neuralgia was not reduced with use of valacyclovir in the time period studied. However, in the strata analyses, participants less than 60 years of age did have a lower incidence of herpes zoster ophthalmicus with use of valacyclovir at 18 months. There was also a reduction in dose of neuropathic pain medication as a marker of severity of postherpetic neuralgia, both at 12 and 18 months. So lesson number 2, suppressive valacyclovir treatment does not reduce the incidence of postherpetic neuralgia, although there's greater benefit in patients less than 60. But suppressive valacyclovir does reduce the severity of postherpetic neuralgia. In some secondary analyses, one of the questions that was asked was, does recombinant zoster vaccine impact the natural course of zoster ophthalmicus and occurrence of new or worsening ocular disease in patients receiving long-term suppressive valacyclovir therapy? We already know that the vaccination is very effective, but we also know that prior zoster vaccine trials excluded those with herpes zoster ophthalmicus. We don't have great data on how the vaccine behaves in patients who have a history of herpes zoster ophthalmicus. And there is a recent study prior to ZETS that showed that there was an increased occurrence or recurrence of disease after vaccination. In this study, the prevalence of having the vaccine was only 23% of the patients, and at 12 months, there was no significant benefit noted with vaccine, whether it was in placebo or valacyclovir groups. This difference was significant at 18 months, but only in the group that also received valacyclovir. So lesson number 3, zoster vaccination is associated with lower risk of ocular disease at 18 months when combining with valacyclovir, and that the vaccination rates are low and should be encouraged, including in zoster ophthalmicus patients. Next question was, what is optimal treatment of stromal keratitis associated with herpes zoster ophthalmicus? This was a secondary analysis of the 20% of patients who had stromal keratitis. In this subgroup, the baseline vision did not change at 12 months, and the dosing for steroids that was required was low-dose steroids, with most of them only needing an increase in frequency. So the lesson number 4 was that low-potency steroids are effective without use of oral antivirals in this subgroup of patients. So just in summary, the lessons we've learned so far are that suppressive valacyclovir low dose is recommended for 1 year. Suppressive valacyclovir reduces severity of postherpetic neuralgia. Vaccination does not increase risk for new or worsening ocular disease with concurrent suppressive valacyclovir, and low-potency steroids are effective for treatment and suppression of stromal keratitis. Thank you.
We'll pause for a moment here and talk about, I think the first few talks. Alan, I guess, and from our moderators as well, Alan, practically how often does this lab actually change your initial therapy of a fresh patient who comes in with an infectious keratitis?
I don't think it changes our therapy, it directs our therapy. You know, if you see a dendrite, if it's a classic dendrite, you're not going to do a whole culture and scrape the cornea and make a new abrasion for the cornea. You're going to probably start the patient right on antiviral therapy, similar with zoster. However, you know, it sort of directs your therapy. It doesn't really change your therapy, and it's one of the first markers that I think that will, you know, if you can make the diagnosis early, you prevent further scarring, partial perforation. So it sets the pathway for getting that patient, getting the ulcer sterilized and improving the patient's symptoms.
Would you say that viral is probably the most, or the finding of dendritic or sort of viral keratitis signs is probably the most impactful on slit lamp examination in choosing versus empiric bacterial therapy and that sort of thing?
Probably yes, but as a little bit of a, taking a little further, typically we see acanthamoeba coming in about a month after symptoms start, usually on antiviral therapy, often because of the perineural infiltrates. So if we can see that, put that together with a good history, and get them treated early, we know that outcome is better, duration of treatment is less, and less scarring of the cornea with better patient outcomes.
Any questions from our moderators?
Yeah, you mentioned, and I totally agree, that a lot of our patients who come to us with corneal ulcers have already been treated for a period of time. Can you speak more about how that changes your interpretation of the slit lamp exam?
Yeah, it changes, it impacts your treatment, of course. One of the things we see is a partially treated ulcer, and you can't do a PCR, or cultures are not as valuable. One of the markers that I find very important, I teach our residents and our fellows at the university, is getting an idea of how the pain changes after treatment. I think it's one of the first markers. It takes time for the epithelium to start to heal in, it takes time for the hypopion to resolve. If you got the patient on the right treatment the day, and you see them the next day, they're going, they come in with relief, so you're on the right treatment. Again, a lot of the times we see partially treated ulcers, and that's often a combination of toxicity from the drops they're on, neuropathic, neurotrophic ulcers as well. Those are a lot more difficult to treat, and you can't use your slit lamp diagnosis as effectively, or your cultures or PCR as effectively as seeing the ulcer for the first time. So yes, it does affect your treatment.
I was just going to comment that I think it is that the chronicity, the repeated exams are really a big part of the evaluation. So when I'm not sure about the diagnosis, you just can always see them back and see the change. And the change, whether it's getting worse or better, is really very helpful in making the diagnosis, or at least how you manage the patients.
Exactly. The other thing is, I talk about risk factors. Normal corneas don't get ulcerated. Last week we saw a patient came in, no prior history of trauma, surgery, contact lens wear, an elderly gentleman, and we thought it was viral and secondary bacterial infection because it came in with the hypopion as well. We did PCR and it was positive for HSV. So, you want to get a good history too. That I think combining a good history along with the slit lamp examination starts the process off in a good direction.
Ellen, I think it's a good point about the pain, is when they start to experience, when they're more comfortable, that's a good sign that you're on the right track. The other thing is, our residents are always looking at the epithelial defect. Well, sometimes that can mislead you because can be toxicity from the medication. So I look for lessening of inflammation almost more than the epithelial defect. I think that's important. And then the other thing that I find very, very important is there's confusion sometimes also I see in the residents is there still infiltrate, or is this scar? And when do you know when the infiltrate is really gone and it's now you're looking at a scar? And what I look for is filling in of clear corneal stroma over the infiltrate. There's always a little depression from where the actual infection was. And if you put in a thin amount of fluorescein dye and look closely without a white light, not a blue light, you can see that little thin strip of clear stroma that now is filled in over the area of the previous infiltrate.
That's an excellent point.
We were having this conversation earlier before this session started about AI. I find even now with our residents, with at least EMR, electronic medical records, they aren't looking as closely at the cornea as maybe we once did when it was not electronic. But do we think that AI is going to make us obsolete? There may be some people in the audience who could also talk about that, but how do we feel like AI is going to change our field and our relationship with the slit lamp?
excellent point. You know, we were just talking about that at the beginning. Are we going to order a battery of tests with slit lamp examination just being one of them? Getting an OCT, seeing the depth of the lesion? Yeah, I think AI is impacting every area of medicine. I don't think we're going to be exempt from the impact in a major way.
Quick question for Shazad. I mean, if you look at the findings or the conclusions from heads versus Zs, much less dramatic with Zs. Why do you think that is?
I think it's a great question. I think there are many different reasons. One is obviously the disease process, the pathophysiology is different than what it is with herpes simplex, and we already know more complex patients to manage and make those decisions. And you know, in my fellowship training, Debbie Langston talked about the art of managing zoster patients, and a lot of times that is still what it is, and we're trying to make it more scientific and having a hard time coming up with true scientifically proven lessons. Some of the challenges of the study were that the enrollment was not as high as it was expected to be, partly from COVID, since that was the time period the study was ongoing, partly from a lot of the patients already, and many of us already feel that valacyclovir is helpful, so we were using valacyclovir as a suppressive treatment to begin with, so there wasn't the opportunity to recruit enough patients to have clear outcomes to be documented. So, I mean, I think pre-study and now probably the audience would say that valacyclovir is reasonable to use as a suppressive treatment for prevention of recurrence of disease. It's safe to use in most of our patients, and it likely has enough of a benefit, and the study sort of is trying to confirm that, maybe not as loudly as heads did for HSV.
I think in a way it confirms. I mean, I always tell the residents I'd rather have simplex than zoster ophthalmicus. I mean, it's just such a complex disease.
Could I just ask you, how has that impacted your treatment? How do you treat your patients with zoster?
So I was not one of those people who routinely used valacyclovir as a prophylaxis for zoster. I sort of treated it was about steroids, anti-inflammatory treatment, not necessarily always using valacyclovir, other than in the pseudodendrites or the epithelial form of recurrence. But now I do routinely use valacyclovir as a prophylactic treatment.
So it has impacted your practice?
For me personally, yes.
Very good. Any other questions? Yes, sit here.
This is a question, Dr. Meehan. Great talk, Shazad. You know, we were using valacyclovir so liberally because of the safety profile, obviously. We monitor renal function and so on. But how does your discussion go with the patient as to the endpoint? So the results are very clear, 1 year. What do you do after a year, especially in a childbearing patient? What do you tell them after that? Do you say you should continue to be on this indefinitely? Just give us a sense of what you're doing.
Great question. So I think that's one of the benefits of the study is that now we have some data to say, well, we have data for 12 months and up to 18 months of benefit. So we can stick with that, but there may be more benefit of continuing on if it's safe to do so. So personally, if somebody's had multiple recurrent episodes prior to this conversation, and that's probably why they came to see me to begin with, or if they have ongoing need for treatment, for example, they're going to need a graft for management of their vision, then I would leave them on oral valacyclovir for a lot longer than just 12 months. Just like we do for HSV, we don't stop at 12 months for a lot of these patients who've had recurrent episodes. So I would do the same here, but at least we have data to show that we have, efficacy for at least 12 months of treatment.
I think in many ways that was a conversation starter. I mean, heads also only gave us evidence for a certain period of time, but subsequent studies were able to show that chronic use is what you needed for chronic suppression. So we may be able to get that with Zeds as other studies come online. Final comment, Dr.
I just wanted to point out how these two studies point out to the passion of ophthalmologists and cornea doctors for the field. Because Peter Leibson, who ran HEADS, said, and he has said it in Academy, that I did this study because I got sued, or he got sued, when he gave steroids to a patient with herpes simplex, and he wanted to prove that it's actually okay. And Elizabeth Cohen had also, for running Zeds, had her own personal stories. and the passion of ophthalmology and cornea docs come out during conduction of these studies. Of course, Sergey Hanush could tell us much more about that, those stories, but all of us, how we could contribute given their patients and their personal journeys.
All right, I'd like to invite next my good friend Jonathan Rubenstein to talk us more about Herpes Simple.
Thank you, Elmer. Elmer and I work a mile from each other and see each other in Italy. So thanks for the invitation to a talk. We're going to have a quick talk, kind of buzz through some of the do's and don'ts every day of practice of herpes simplex keratitis. The diagnosis, as Alan has alluded to, is usually clinical. We usually can make this diagnosis because of the clear dendrite that we see on the cornea. But you can also use other things like viral culture, conventional PCR. Now we have microfluidic PCR available for some people with a rapid diagnosis. Some research into CRISPR technologies and multi-dot hybridization technologies coming. But most of this talk is going to be based on treatment. So what are the principles of treatment? Epithelial debridement is still very important. It's been around forever, but it decreases the viral load and gives us a specimen potentially for culture. Obviously, use of antivirals, which we'll get into, use of steroids, which we'll talk about, which is very important for the control of inflammation in zoster. Obviously, you want to treat with antivirals and epithelial disease first, but don't forget to use chronic low-dose steroids for suppression of inflammation, and make sure that we're ruling out and thinking about acanthamoeba when we put some of these patients on steroids because of some of the confusion that can occur in the clinical presentation of these patients. We'll talk about non-healing epithelial defects using bandaged contact lenses. Synergement is a possibility as well, and ultimately some of these patients do go on to surgery, either superficial surgery like SK or PTK, or deeper surgery like a PK or DALP, but always with postoperative viral immunosuppression. So current treatment, antivirals. The drugs are either given topically or orally. We have trifluridine and ganciclovir gel topically, acyclovir, valcyclovir, famciclovir orally. Uses are for epithelial and stromal keratitis and prophylactic uses, which we'll talk about. And steroids, we can't forget to use steroids, and we'll talk about this a little bit more, but that's an important adjuvant, especially with stromal keratitis, endothelialitis, trabeculitis, or uveitis. So more specifically, how do we treat epithelial keratitis? Again, we talked a little bit about debridement and antiviral use. So often, if you're going to give oral, in the States, we're usually now using ganciclovir gel 5 times a day till the defect heals, and then TID for another 7 days. Trifluridine is a little less used, but still out there. Darabine is less available now these days. And orally, the other options are acyclovir, valcyclovir, or famciclovir. And in the States, valcyclovir is really taken over as the leader of what we use, 500 milligrams PO/TID. Watch for signs of epithelial toxicity if you're treating these people topically. That can confuse the issue as to whether this lesion is really healing, whether there's still presence of infectious disease, or whether you're just looking at epithelial toxicity. For stromal disease, we usually think of treatment in these 3 categories: infectious stromal keratitis, endothelial keratitis, or immune stromal keratitis. The first 2, you can see the treatments are the same. So it's acyclovir 400 milligrams 500 times a day, valcyclovir 500 milligrams PO/TID, so a little easier course for the patients, famciclovir 250 TID, and topical steroids in infectious stromal keratitis and in endothelial disciform keratitis. For immune disease, where you're really confident that there's no active infection, these are in lesser doses and actually the same doses we use for suppression. So acyclovir will be 400 PO BID, Valtrex 500 PO a day, famciclovir 250 a day, plus topical steroids, very important. Again, these are the same doses we use for prophylaxis, acyclovir BID, valcyclovir 500 a day, or famciclovir 250 a day with topical steroids. And usually we give the topical steroids dose per dose, so we give the same dose of pills and drops. Some other potential new therapeutic options for herpes simplex, and the 2 I'll mention specifically are the helicase primase inhibitors. Pritlivir and menavir are potentially up and coming, and there are new CRISPR technologies that look like they may show some promise in the future of treatment of herpes virus disease. So all these therapies are really spun out of a relatively old study now, which is the HEAD study that Elmer referred to, HEADS 1. It's a multi-center national prospective trial, occurred in 1994. Some of us in the room were actually involved in that study. Showed that oral acyclovir was not significantly beneficial to concomitant topical steroids and trifluridine in treatment of HSV stromal keratitis. So using the oral wasn't a real benefit to the topical steroids and trifluorophenidine. It also showed that topical corticosteroids were helpful in reducing the progression of HSV stromal keratitis when added to topical drops. Those are the main HEADS 1 findings. HEADS 2 then came out a couple years later and showed these major findings. In the iritis treatment trial, acyclovir 5 times a day for 10 weeks was beneficial in control of the iritis. The epithelial keratitis trial, EKT, showed that adding acyclovir was no better than virotic or topical drops alone, so it was one or the other that seemed to be equally efficacious. And the acyclovir prevention trial showed that 12 months of acyclovir, 400 BID, did reduce the rate of HSV recurrence. So this is a little bit tuned in with what we found out just in the ZEDS trial. So prophylactic acyclovir did reduce HSV recurrence over a 12-month period. And in the RFS recurrence trial, the most important correlations are really with inflammation in HIV patients, and some of the misconceptions were that sunlight, menses, stress, contact lens wear really didn't seem to have an increased incidence of recurrence. So again, principles of treatment. For persistent neurotrophic epithelial defects, you want to treat with lubrication, bandage contact lenses. Sometimes scleral contact lenses can give you a fluid film under the contact lens that helps. Amniotic membrane, we now have bright mem allografts, tarsorrhaphy, serum tears, and synergium oxybate. It's been very helpful in some of the neurotrophic keratitis that presents after people have herpes simplex stromal disease and keratitis. Of course, there are surgical treatments, PK, ALK, or DULC. You want to give post-op antivirals, usually oral antivirals, either acyclovir or valcyclovir, for at least a year or while they're continuing on topical steroids. So if you're continuing to treat these patients for years on topical steroids, you should probably treat them as well with oral acyclovir or valcyclovir. Conjunctival flap can be useful in some of these patients with terrible non-healing defects. And for superficial disease, you can consider superficial treatments like PTK or a superficial keratectomy, as long as you continue them on antiviral treatments. These are important because recurrence is high. It can be as much as 50% at 5 years or over 60% in their lifetime without prophylaxis. So you want to be able to treat these patients aggressively and long term with antivirals and topical steroids. So our last take-home points are, what are the don'ts? Don't use steroids initially with epithelial keratitis, but don't avoid steroids or stop them too early for stromal keratitis. What are the do's? Treat epithelial disease with topical or oral antivirals, but not both, one or the other. Orals may be preferred because it reduces the chance of toxicity and confusion from the toxic effects of the drops. Watch for the toxicity from drops. And lastly, use chronic long-term topical steroids plus antivirals to treat chronic stromal disease and the inflammation that ensues with that. Thank you very much.
Thank you. Excellent talk, Justin. Thank you so much. Next, I'd like to invite Dr. Afshari, another very good friend of mine, who will be talking about takeaways for fungal keratitis.
Thank you, Dr. Tu, and the panelists, and a special thanks to the Sarnicola family for their invitation to be here. What a beautiful place, really heaven on earth, right? So I'll be talking about fungal keratitis management, some of the evidence-based clinical takeaways. These are my financial disclosures, nothing relevant to this talk. So why fungal keratitis still matters, and we and others have studied because it's still 30 to 60% of microbial keratitis in tropical regions are fungal keratitis. So we have this major cause of unilateral blindness and delayed diagnosis because it's tougher to diagnose compared to bacterial keratitis. Remains the strongest modifiable outcome for these patients. There is the clinical severity that's driven by the organism virulence, fungal load, host inflammatory response, and then the treatment delay is an issue because of the diagnosis. And we could see in this global map that in certain regions we have a lot more of the disease. So clinical takeaway is that clinical suspicion remains the paramount of this infection. And the number of risk factors that we have, the trauma with vegetative matter, the chronic steroid use, the agricultural work, the contact lens wearers, the ocular surface disease. And then, of course, we have our diagnostic tools. Some of our other colleagues talked about it. With different sensitivity from smear, KOH, gram stain, culture to confocal microscopy that now we have with rapid, excellent, and particularly for filamentous fungi. And then the PCR that Dr. Rubenstein was talking to us, increasing role, but of course, variable availability. Let me show you this case, and I'm interested to know what some of our colleagues here would do. This is a 77-year-old man who came to us with keratitis associated corneal perforation, had history of a corneal metallic foreign body and HSV in the left eye several years before, and I treated this perforation. I was actually early attending as an assistant professor, and I put this patch graft on, right, because of the perforation. Well, then on post-op day 1, the patient was 2100. Bacterial and fungal cultures that were obtained intraoperatively from the edge of the perforated cornea, and the donor rims were negative. He was on topical vancomycin and amikacin, and then he was on some oral antiviral, and then the Predforte. Then the patient goes back to work. He actually worked in a tobacco factory. And then 4 weeks later, he experienced decreased vision, increased irritation, and the infiltrate covered the entire patch graft, a dense infiltrate within the tectonic graft. So what would you do at this point? Of course, just like all of you, I did culture, and the culture showed this: Aspergillus, 2 species of Candida fusarium, as well as Corlaria, right? So multiple, 5 species of fungus. This is what's in tobacco. This is the inverse in tobacco factory. Also, viral cultures showed herpes simplex virus. As Dr. Rubenstein said, wow, and yes, we did report the case. But the question is, what would you do at this point? What would you give this patient, right? So perhaps the kitchen sink, right? So stop steroid, because now we have this fungal infection, received topical and oral antifungal without improvement after 5 days. Now what do we do? So I did a therapeutic PK with a 9mm eccentric graft, as you could see here. But then, right afterwards, it seemed that the anterior capsule of the lens was violated. Or was it violated, or was it fungal material in the anterior chamber at this point? So what was it? And of course, we had this polyfungus situation on pathologic examination. We had everything, the fungal hyphae and this in the stroma extending to the decimes. Now I gotta worry about the anterior chamber, and if it's all the way in the decimes, do we truly have fungus in the anterior chamber, or is it that the anterior lens capsule is gone and therefore we have some leaking of the material? Is that what it is? So there was also persistent epithelial defect, and the pressure was high too. So at this point, I repeated a penetrating keratoplasty and did extracapsular cataract extraction, the open sky, a glaucoma tube placement because the pressure was quite high. Didn't love to put glaucoma tube at the same time. And intraoperatively, so during the surgery, I did a KOH examination of aqueous humor that actually luckily showed no evidence of fungal element, and culture was sent for corneal button, which were negative, and then cataract extraction without any complication, but at least decided not to put yet another device in the eye, held off on the lens implant, but the patient had to get the glaucoma tube because of the pressure, and topical steroids were held, but the patient did get cyclosporine because we know cyclosporine has the antifungal abilities. And here, 12 months later, his eye remained quiet with a clear graft, no evidence of recurrence infection, and best corrected visual acuity of 20/25. This is the most number of fungal species in any eye that has been reported once we reported, because it was 5. So some of the takeaways from the different trials in fungal keratitis. And this is from my trial 1. The fact that natamycin is the first line of therapy in that randomized clinical trial. Natamycin versus voriconazole topical were checked, and there was better vision, lower perforation rate, and greater benefit, particularly for fusarium. And the clinical pearl is to consider natamycin, not voriconazole, as first line of therapy for filamentous fungi. So how about voriconazole? Where does it fit? And with MOT2, adding oral voriconazole did not have visual benefit, no reduction in perforation, more adverse events, including hepatotoxicity and visual disturbances. So, but voriconazole can be helpful in deeper infections, in poor natamycin penetration, in resistant disease, in yeast infection. But then to think about each case, what would it require would be helpful. What about emerging therapies? Well, we have the collagen cross-linking and all of those possibilities. But in my laboratory, we developed a mouse model of fungal keratitis. And by the way, it's amazing. Unlike humans, mouse really resolve the fungal keratitis themselves. But so we have to immune suppress them with systemic immunosuppression to get the fungal infection. But so we tried different possibilities, and here it is: PHMB, polyhexamethylbiguanide, which are costing pennies. It actually works as a very nice antifungal treatment, particularly for aspergillus. Actually, based on that, we wrote a Gates Foundation grant, and it did not get funded because they were looking for, they are not interested in fungal or any bacterial infections, but we learned that pennies, a pool cleaner truly can reduce and treat the fungal infection. So practical management is when we have the suspected fungal keratitis, we scrape, we do microscopy, natamycin, check 48 to 72 hours later, repeat scraping, and then at times we have this role for therapeutic penetrating keratoplasty. So final take-home message: early diagnosis matters more than sophisticated diagnosis. Natamycin remains one of the first lines for filamentous fungi. Oral voriconazole is not routine, but considered, of course. Surgical intervention should not be delayed in progressive disease, and evidence should guide adoption of new therapies. Thank you.
Thank you very much. So brief discussion. Any questions from our moderators for the previous 2 speakers? I have a quick one for HSD. When treatment fails, Jonathan, you know, if you're on orals or on topicals, what do you do at that point?
Other than send them to you?
Nix.
You have to think, first of all, if you have the correct diagnosis. So if your treatment fails, you have to reassess whether you're directing your treatment towards the correct organism and the correct diagnosis. There are some other treatments that are, as you know, there are patients that are resistant potentially to some of the conventional oral antivirals, and so there are other antivirals that you can give for treatment-resistant organisms as well. Cidivofir is one of them. Foscarnet the other, right? So that's probably what I would go to if somebody's truly resistant. But the first thing you have to think about is, are you treating the correct, did you make the correct diagnosis? Initiate the correct treatment for that diagnosis.
But when you have a first episode of epithelial herpes keratitis, which antibiotic do you use, oral or topical?
As initial therapy.
Initial therapy, yes.
I've gone more towards oral, and probably because I'm trying to avoid the effects of the topical. I think that the compliance for the patient is a little better with oral than with drops as well. So I feel that the idea is you want to get the proper therapeutic into the patient's system as easily and as least toxic as possible. So I usually go with oral. And I find it decreases the confusion of epithelial toxicity that comes in. A lot of us, as we know in cornea, get patients that are referred in with herpes keratitis, and the referral doctor says this patient's just not getting better, and we see them and we realize toxicity is the etiology of the problem at that point. So when you give them oral medication, you decrease that chance.
In the audience.
Yes, please.
Hi, thank you. Congratulations on all the talks. I'm Branca from Brazil. My question is on recurrences of stromal keratitis. Whenever the patient is dependent on corticosteroids to avoid recurrences, but he's also developing high IOP and difficult to control IOP with all glaucoma medications, do you try anything different like cyclosporine or tacrolimus?
Yeah, it's a great question. We see this all the time because sometimes these people also can get trabeculitis, and so they can have reasons for high pressure. So there are more they're pressure-sparing steroids, so loteprednol is a possibility. Cyclosporin is a possibility. None of these are quite as effective as prednisolone, but those are also possibilities as well. And even potentially, possibly switching to an oral prednisolone could do it as well.
For Dr. Afshari, you had mentioned the topical calcineurin inhibitors in the context of fungal keratitis, and that they might be relevant for treatment as well as perhaps as an anti-inflammatory. I find myself using them earlier and earlier in the treatment of these patients. I was curious how you think about it now.
Yes, I agree that I use them. I also use them earlier, Dr. Nalazam. Is it harder to treat fungal keratitis?
Turn this on. So anyhow, yes, I use it earlier, and sometimes I use it in combination with other therapies because fungal is so hard to treat. And we were talking about earlier, looking at the slit lamp and seeing the differences that you were saying, or their pain, and it takes so long for them to be better that I never know when we are at that viewpoint of making the U-turn in these patients.
Any experience of conjunctival flap?
Yeah, I know, sure.
I have done conjunctival flap when I felt that I am about to really lose the battle. What is your experience?
Well, conjunctival flap, it's sort of like a sweet spot. It's hard to find because sometimes it's too deep, to be able to get into the, danger zone of perforation. But there's some cases being reported of almost like perforating and doing conjunctival flap, as I'm surprised, but I would not do it in perforated cornea. But in kind of like superficial, like sort of like early melting and not respond to treatment, that's the sweet spot, and peripheral as well, pericentral. And for herpes, I don't have much experience in conjunctival flap, but Gunderson back in the years, they didn't have a cyclovir or any antiviral, and that's how they started, treating these corneal ulcers as well, initially for herpes.
I think one of the things with the flaps is that if it's an endophthalmitis, you can't do it. It's not going to help. The eye will just develop underneath.
Actually, I can't remember the last time I did a conjunctival flap, period. So I think it's not used quite as much now with nerve growth factor, aggressive use of tarsorrhaphy as well, and being hopefully smart in your treatment so you understand when toxicity may start occurring and starting to treat the epithelial kindly rather than poisoning it with medication often can lead to resolution of the epithelial defect, hopefully before going to a conjunctival flap.
Charlotte?
What are your indications and technique of intrastromal voriconazole?
I mean, it's really straightforward. I don't know. It's basically, if you can hydrate a cataract wound, you can do an intrastromal injection. So that's what your end point is just to get it into the midstroma and inject and get corneal edema, basically.
You know, one thing that I worry when we do stromal injections is if the lesion is deep, oh, am I just going to introduce it into the anterior chamber by micro seeding? Do any of you worry about that? And I think that's probably what you're referring to. Yet, sometimes we have nothing else left.
I think one of the misconceptions about stromal injections is that you're trying to inject the ulcer. You're not. I mean, you basically want to inject away from it somewhere where you have normal cornea to create a depot. You don't have to inject. You shouldn't inject right into the ulcer itself. So that'll reduce some of the risk, I think. So.
How often do you redose intrastromal injections?
Once a week. Okay. All right, very good. I think we'll move on. Dr. Martinez is going to talk to us about, start off our session on interesting therapies, which we're going to start with rose bengal keratitis photodynamic therapy, pioneered and certainly
Hi, good morning. Well, first of all, thank you. I'm really happy to be here, first time in SICSSO. I'm so impressed about this meeting. I don't know how did I miss it so many years, but probably I will hopefully come back more often. So I'm going to talk about rose bengal photodynamic antimicrobial therapy. And I do not have any financial disclosures on this talk. At first, I want to mention a couple moments about Dr. John Marie Burrell, that is one of my mentors, who was initiative on this therapy many years ago, and as he passed away last year, and as he said, patient first, and family second, I want him last. He'll be those person who will be 4 o'clock in the morning working, all day. It's an amazing person if you ever met them. Of course, anything is possible. Nothing is possible with a team, and thanks to Dr. Romesco, Dr. Dario Miller, and the whole team of Rose Bengal PDT. Well, we have great lectures about this morning on our pros on diagnosis. So who thinks this is a, bacterial infection? Raise your hand. Good. Contact lens user, that's a giveaway, but who thinks it's a Acanthamoeba infection? Great. So, yeah. So unfortunately, it's really disappointed, and frustrating when you see these patients end up like this, when a big seal, no matter what you do, no matter if, you give your patient your WhatsApp, and it's, and it ends up being these terrible outcomes. But, we have cross-linking that has been published for many years with success of bacteria, but unfortunately, Acanthamoeba and fungal infection has been sort of inconsistency results. So how this rose bengal plays along in this treatment. So rose bengal actually is being used as antimicrobial in the botanical many years ago as an antimicrobial treatment, which activates with green light and creates a photosensitivity reactive oxygen species. And actually, rose bengal is one of the most efficient single oxygen generator. So how do we do this treatment? So rose bengal treatment, we place 0.1% of rose bengal. We let it soak on the cornea for about 30 minutes. And we actually, you see this red light on the room, because it's hard to, if you put normal light, it will activate the rose bengal while you're soaking with the regular light from the room. So we use red light in the room so it does not activate, and we use a sponge of 8mm sponge, soak it prior with rose bengal, and the green light treatment for 15 minutes, as you can see. So what's the historical timeline? So first it was 2014. They published in vitro studies against Fusarium, Aspergillus, and Candida, and Staph aureus resistant. It was good success results. So this motivated to continue the journey. The first phase was a Fusarium infection in 2017. Back then I was a resident fellow. So 2019, the first case series we published of a success rate of 72% with 17 cases, retrospective study that prevented a therapeutic corneal transplant, again, as a last resource, no initial treatment, really bad corneal ulcers. And continue that, we have a couple cases, papers, and actually, doctor, I recommend this paper. It's great. It's an updated version from the 10 years of data with Neil Parisha. He published with Dr. Mesqua about management and algorithms of corneal ulcers, which include a rose Bengal PDT treatment on it. So what about other groups, such as in Dr. Graue and Dr. Ramirez and Alejandro Navas published some cases, and as well the most updated, we have Dr. Bupesh as well, presented the results with acanthamiba. We have other recent paper with Dr. Graue and his team with a 61% success rate in Mexico. So we did a case, a retrospective study with a cutoff on 2023 for about more than 100 patients, 103 in total with exclusion criteria. By now we probably have more than 150 patients. And we have, interestingly, we have a lot of acanthamiba. In Miami, we have a lot of infectious acanthamiba. Surprisingly, compared to other case retrospective studies, there were not a lot of acanthamiba. 47% of acanthamiba, followed by fungal infections such as Fusarium, and bacterial infection, Pseudomonas. So what's the result? So the results was 76% success rate. How did we call success? Success was to prevent a emergency cornea transplant, but there were really bad ulcers such as last resort. Some of them were limbus to limbus, and as a last resort. So we prevented surgery in about 55%. Prevented of having a cornea transplant. The success rate, it was bacterial, 76%, followed by fungal, and acanthamiba, 69%. So overall, the transplants, they had a good response to treatment and follow-up without graft reinfection in 6% only. So it's pretty good, low, but not perfect. So why we don't have great, like more than 90% success? Why? I mean, there's a lot of studies that we have to look at details, maybe antibiotic resistance, last resort cases, challenging cases, limited corneal depth penetration, or late-stage severe disease. I will comment a quick case. It was a firefighter who had treated a really bad corneal infection, which actually he was using these Esricares artificial tears, which they were CDC alert. They had a fungal, Pseudomonas resistant infection. So we did in vitro studies using the rose Bengal treatment with good success. So we motivated us to treat it with a rose Bengal, and actually you can see resistance to everything. Maybe some compound that you could use, but hard to find. So I remember bringing the vials and putting on the chocolate plates, and 2 out of 3 were positive of the same organism of Pseudomonas, resistant to everything. So how did the patient did? The patient did really good. I am doing doubt treatment, surgery on a quiet eye, on a scar eye. Now it's been probably like 6 years, and of course, with the teaching of Professor Sarnicola, I had a good success result, vision outcome. So limited penetration, cornea, rose Bengal penetrates only 200 microns. It's not a lot. Some of these infections are really deep, and it's hard to get into the infected part. Late stage disease, so we need more randomized clinical studies, to be able to know the actual outcomes. The recent paper and study that Dr. Rose actually presented yesterday with the results, it was presented at the Prashna last year in Cornea Day, where he found no evidence of rose Bengal versus sham on visual acuity, but some success vision on Fusarium. Aspergillus was the worst vision on rose Bengal PDT. Aspergillus was really hard, which actually in our case series we didn't have much Aspergillus compared to Fusarium. So Aspergillus is a difficult one. We need more studies. So in conclusion, rose Bengal could help resolve and prevent corneal transplant. We need more randomized clinical studies, to prove this. Thank you very much.
Thank you, Jaime. That was great. And then our last talk will be Dr. Sarnicola, talking about therapeutic keratoplasty, what we're trying to avoid with rose Bengal PDT.
Good morning. As you know, my English is not very well, and consider that last night we went to sleep very late, so this morning is a little bit worse. So I'm speaking about therapeutic talk, when and how. I'm speaking about the case where the medical therapy is not working enough. What it means we will discuss later. But we are speaking about severe infection like acanthamoeba and fungal keratitis. You have just seen that the management is not easy, and 1% of these patients need keratoplasty. We don't have experience with the other infection, just with this. So if we look the complication of therapeutic PK, that usually is a late therapeutic PK, the graft failure is very high, and a lot of the complication has to be seen and managed, and sometimes we can lose the eye as well. So our approach is not anymore PK and not late timing. So we should be good doctors choosing the patients that need keratoplasty, and the patients that need keratoplasty have to receive deep anterior lamellar keratoplasty and early approach. Just a few minutes about the surgical technique. You can see this case. It's a deep 250 micron in optical zone, and so in this case, in the best opportunity, we'll develop a glaucoma in optical zone. So we want to eradicate the infection soon, making a deep debulking and very large incision. At the end of surgery, we want to know if we really eradicated the infection. So we have to study how can we know this? Studying the peripheral margin that should be free of infection 1.5 millimeters, and the deep margin. So if we find that we really eradicate the infection after we have sent this piece of anatomy to the pathologist, we can manage the patient much better. So how can we prepare the tissue for the pathologist? Easy. So if the incision was 8.25, 8.5 at least, we can use a smaller punch and prepare the peripheral margin, like you can see here. The ring that is 1.5 millimeters has to be sent to the pathologist and ask him if it's free or not of the infection. And then the other part can be studied to evaluate if the infection is active or not. So at the end, we should know even how is the deepest part of cornea of the stroma, and how can we prepare the deepest part. Spiral peeling off technique, that is probably the first original technique to perform a dark. It's now rediscovered with this modification. So with the spatula, we work in the periphery, looking for the deepest plane, the pre-Deschmatic plane, where the deep stroma can be peeled off from the eye. And how can we find this plane? We go turning around deeper and deeper with the spatula and cutting the tissue, as you can see here. And we have to be very patient. You have seen probably in my live surgery 2 days ago. And you go deeper and deeper until the tissue can be peeled off. you can see here. Even with spatula, you start to peel the tissue, and with the two time forceps, teeth forceps, you can peel off the tissue. When you are able to do this maneuver, it means that we are really very, very deep, and the residual bed is more or less 50 micron. And we can send this piece to the pathologist and ask him if the deepest plane is free of the infection as well, like you can see here. Okay, at the end we can put the donor. And surgery is finished. So look what happened after 10 days. We received the answer by the pathologist. The peripheral rim is free of infection, the deep margin as well, and the centerpiece has active infection. At this point, we can stop the targeted therapy that has a lot of toxicity, and this is 9 months post-op. This is a fungal infection. The approach is the same. I don't want to lose time showing you the surgery another time. And this is the 1 week post-op. And I want to focus on a new experience that we are meeting now. The patients that had fungal infection, after 1 year, 1 year and a half, it's easy that develop a new infection, a new fungal infection. So in this case, you can repeat dark. You can see these patients, for example, this other one, and you see that surgery is very easy because it's repeating dark. Video is not starting, okay. So you see, you just remove the stitches, and to repeat the keratoplasty is very easy, and you are doing surgery without open anterior chamber, and you can regraft easily. And this is the post-op, so you see the result is very good. And look this, we should think about the aspect, rejection and survival rate about a PK related to talc. We know that without infection, the regraft and rejection are much more frequent in PK, and the survival rate is very low in the PK, and is much better in deep anterior lamellar keratoplasty, even rejection and survival. So at the end, I want to focus on the last concept, that with the acanthamoeba infection, we have more time to decide to wait a little bit and do dark, but this is not possible with the fungal infection, because fungal infection is very fast and sometimes can destroy the eye in a couple of days. So at the end, don't forget that with the acanthamoeba, you can wait a little bit, and you should be with a prompt decision if you have a fungal infection. Thank you.
Me.
You can stay there. Even better. Thank you, Enzo. Thank you for that talk. So we'll go over, these are both therapies for sort of more resistant or advanced keratitis. Timing is always the issue, right, in terms of trying to figure out when medical therapy fails. And sometimes that's time, sometimes it's slit lamp examination.
Yeah.
What do you think, Enzo?
It was the last slide that I didn't have time to comment.
Well, now you do.
Can you give me again?
Can we show the last slide from Dr.
Mi ridale mie slide, per favore. Well, anyway, now we know that if targeted therapy starts late, the possibility that we need acanthamoeba cornea transplant. What is? Many cases, sorry. Buongiorno. Mi ridà le mie slide? Dalla prima, per cortesia. Anyway, targeted therapy is very important. The answer to the therapy is very important because you should closely follow the patient, especially in fungal infection. We double check the patients even 2 times a day if we suspect that therapy is not enough. And if we do not see an improvement, especially for fungal, we go straight then to the doc, because fungal can become terrible in 1 day sometimes. And because probably, I've seen in the literature that between 50 and 70% of fungal infection lead to keratopathy. I don't know if somebody concurs this.
Full circle back to Alan, he was doing the slit lamp thing. I mean, what are the signs you would look for either deep involvement or time for keratoplasty?
Yeah, certainly it's how long they've had the infection, how long they've had the pain, how long it's been going on.
Yeah.
You want to use the slit lamp exam to see the depth of the lesion. The question I wanted to ask you, you mentioned go early for fungal keratitis to your dog. Do you treat your fungal keratitis dog with cyclosporin or a topical steroid afterwards?
After the dog?
After the dog.
Absolutely no. Absolutely no.
No steroids?
No, only antifungal.
So you would do it the same as if you did
I want to be
keratoplasty, you would
before
try to...
starting steroids, I want to be sure that infection is away. And then I know that cyclosporin can help, but I don't need it for a dog. I'm not doing a PK.
Yeah.
If I was doing a PK, I would use cyclosporin as well. But in a dog, I don't need it. So just, yeah.
Do you wash the residual decimates or deep stromal bed before you put on the new tissue? And do you put on some sort of antifungal wash or drops?
Yeah, yeah. As we showed in a larger manner 2 days ago, Enrica done, when we debug, we wash the recipient bed with voriconazole and
Beta-tine?
yeah, before to put the absolute.
How do you manage the inflammation?
Instruments, gloves, and yeah.
How do you manage the inflammation post-dog for infectious keratitis?
But I try the gun every morning. That's a perfect. And then I call the patient and try. Because you're close to the ball. You're not.
I think you're closer to God than us because when I pray, it doesn't
You're
always.
always good. And
Elmer, in this section, we didn't really talk about imaging in terms of confocal microscopy as much. Can you comment on being able to use confocal microscopy or other imaging tools to detect those deep infections any better before making that decision about dog?
Well, I mean, confocal, I think is more of its best benefit is a screening tool to try to determine. I think depth in a cornea that doesn't have much opacity, or you can tell depth by confocal microscopy, but I think OCT, anterior segment OCT, may be better if you're trying to determine depth. And slit lamp examination. I mean, you know, you have to be skilled at that, and I think then you can make better decisions on timing.
A question for Dr. Martinez. What was your criterion for going to your PDK therapy? Was it a certain point where you felt there was no progression or failure, or how long did you wait before you initiated that therapy, and what was your criterion?
Yeah, it's the same difficulty as, you know, other treatments like conjunctival flap and transplant, but definitely he's not responding for more than 2 weeks, and with, you know, to topical treatment, and it was a severe infection that next step would be required to do a corneal transplant. That was our criteria, because we cannot do it early stages, as you know, there's no approvals for this Rose-Bengal PDT yet. And sometimes we needed 2 treatments or 3 treatments. That's something that different.
thing that we did find in our limited experience with cross-linking patients with deep acanthamoebal disease, it was a disaster. These patients would melt and get more inflammation. Did you ever see that in trying to do PDT in the more advanced cases?
Yes, so I noticed inflammation in certain cases, that it gets in the gray zone, that it's inflammation or you're actively killing infection, and it's sort of like an experience that you feel that we noticed that it will increase sort of inflammation into hypopyon. Just wait a couple weeks, sometimes you have a block, but in 3 months time it will sort of like, the patient will say, I don't have a spleen before. So that's sort of like things lingering into waiting. It's hard, I know it's kind of subjectively, and then sort of see that the eyes a little more quiet and things like, but it is tough. It is tough to know if it's inflammation or the infection is getting worse.
Thank you, Jaime, for the great presentation. How do you put together your great clinical experience with the paper that showed, a lot of times no difference? And the reason I ask the question is, I was on the Data Safety Monitoring Committee of the trial, and Jen was earlier too. And obviously, as a cornea doc, I really wanted it to work, and yet so much of it was no difference. Yet clinically, we are seeing that it's working, as you are seeing.
Yeah, when we saw the results, it's disappointed because you've been using it and you're seeing the improvement, and you see many eyes that have been saved for these cases. But compared to the trial, maybe you can think of different things that we've done. Sometimes protocols are, we kind of modified, through the years. And one of the way we did 2 treatments, sometimes we did 3 treatments. I don't know if that will make any difference compared to the clinical trial. And each organism is sort of like we have to see it differently. Like Aspergillus is sort of different than other Fusarium. So it's not, one treatment will work for every single organism. So that's pretty much maybe I can support, my kind of my results. Yeah.
Dr. Woodward, you had a question?
Hi, yes, a question. I personally am very interested in imaging in keratitis. Mia Woodward, I'm from the University of Michigan, so I almost have to exclude those 3 from the answer because we do use the lamp imaging regularly at University of Michigan. But what I'm hearing from the panel is that y'all are using imaging very specifically, right, for a diagnostic confocal decision or a prognostic, when to use a adult, how deep an infection goes. And I'm curious how often y'all are using imaging and in what context you're using imaging in infectious keratitis, or is it really just ad hoc in the moment for a specific, reason for that day?
And so do you want to take that?
Yes, I understood more or less 45% of your talk, but at any rate, I can imagine what you want to say, and because I speak slowly. So surely we follow the patient with the imaging, and we do not do surgery if we see that medical treatment is working. So we only do surgery when we are almost cannot be taken away, almost sure that medical therapy is not working. And because the risk is high, we prefer surgery when we don't have the control of the infection. We are not sure, but especially for fungal. For fungal, our approach is much more aggressive. For acanthamoeba, we take time because the progression of infection is a little bit slow, much more slow. And so we decide if the infection has a progression. If it's stable, we don't do surgery, we wait. But let me say that sometimes we have seen acanthamoeba infection that we are sure that the patient is free of infection, but the cornea become thinner and thinner and thinner. At that time, I do surgery. I don't wait.
Do you even need imaging for that, I mean, I would trust your slit lamp exam implicitly. Yeah, I would trust your slit lamp exam implicitly. But I'm just curious if you feel imaging supplements, because I mean, I think your results are amazing. I think we should all be doing this more. I'm just wondering if the imaging you think adds to your. I mean, our Branca colleagues use it constantly.
I agree.
Okay.
It's very important to continue to speak with God. Because it helps a lot. And I want to say something that, so the results of only dark are very good. And you are sure that you are saving the eye. And especially if you have an ulcer that is more than 200 micron, even if the medical therapy will be able to heal the eye, the patients will develop a glaucoma or irregular astigmatism, and he will need surgery. And to do this, he's using therapy for months and months. And you never know if you can fly to Italy to come to SICSSO meeting because your patient is there and you cannot follow him. So there are many conditions that can make a strong influence in your decision.
Very good. And I think I can speak for our panel that it's been a privilege to be part of SICSSO. Thank you very much for...
Thank you to you. You are enlightening this meeting, and this meeting is growing. Don't forget you that is growing because then. It's very important that we have a great faculty, because with a great faculty the young people can be emotional to do better and better, to improve the knowledge and the connection of a new generation with me and generation. That's very important. That's very important. There are many young people here.
So that concludes our session. Thank you so much for coming on the first session of the last day of the conference. And I want to thank our speakers and moderators this morning. It was an excellent session. And if you have questions, I think we'll be up here to answer them if you have them. All right? Have a great rest of the day.
Remember Ed Holland's paper on herpes nomenclature? Did you ever?
I'm sure I've seen it before, but I don't remember.
I thought it was really good. So, and I tell the residents that also. You know, it's infectious epithelial keratitis. So it's the anatomy and the pathophysiology, and then immune stromal keratitis. You know, so people would call it, but that's how they would communicate.
Hey, how are you?
Caught you for 2 minutes yesterday, and I thought, okay, you're right.
Good, good. Oh, we have to do a picture of it.
I was just saying, Ed Holland, he had a nomenclature for herpetic disease. And I try to use it all the time for the residents. You have infectious epithelial keratitis, you know, either dendritic or geographic, but it's infectious. And then immune stromal keratitis. What's the pathophysiology? Immune stromal keratitis. Or necrotizing stromal keratitis, and then endothelias. I mean, so when the resident would come, I would say, this is an infectious epithelial keratitis. We try to always use that nomenclature. He wrote a paper, I thought it was great.
So in the book, he has this picture of something called endothelium, right? It's an old man, it's basically, and it's basically, it's like UFO. It's basically, and it's something like nebulae endothelial lesion. It's turned out to be. See, then we knew what it was, and it turned out, because obviously years later people do physiology, and it turned out to be but he called it nebulae, and it was such a new, and then I had asked those residents, what's that? And they go, it's then I realised you might as well call it UFO basically, because there's no idea. But alright, John, great to see you, man. I'm going to go flying out to, we have a tuna meal. I have a date with a tuna chef in 2 hours, and then we're flying out to Doha back to the airport. Good to see you, man. Okay, and remember I told you the date. So I'm gonna send it out and stuff and things to block the calendar and have it. Let me know. I want to see your Harvard picture. I'm sorry, I need to see your Harvard picture and stuff and things. So I seriously, I really want to see. I've thought about this when you mentioned it yesterday. I thought about it, but I'm just scared. I can't handle -50, man. I mean, it's like it's a level for me that's beyond my level. Yeah.
A man, as Clint Eastwood would say, you know, and all those things. Yeah, a man needs to know his limits.
Yeah, absolutely. All right, take care, man.
What does that even mean? I'm with you on that. No, I'm with Alright guys, I'm gonna take a photo. You gotta I'm trying. I will attempt. I'm sorry. Okay guys, we got the background. Oh, the background is in. Everybody look at me. 1, 2, 3. 1, 2, 3. Beautiful. Beautiful. We have to do one more of Michigan.
That's Michigan only.
Oh wow! You know, my husband went to Ohio State. I'm not sure I can take this. I'm not sure I can take this photo. Well, I know it's going to be a picture of me. No, I'm just kidding. I'm going to send it to him. My husband's son is like 6 years old. Great job. Great job.
Yes.
Yeah, what did you get? Some pictures. I'll send to you Thursday. I have heard like here's Rufus.
Years ago.
How are you, my friend? Very good. Nice to see you.
That beard was the only thing that changed. No, but mine doesn't just have my email.
Oh, your email.
Yeah, but that's okay. I have her phone, so I can text you. Yes. I think I'm close. 1, 2, 3. I can send it now. I have
WhatsApp?
you. WhatsApp. I didn't know you guys use WhatsApp. Yes. It was so hot where people were dancing that it was a little bit.
I'm sorry.
No, I was a little bit behind, dancing behind, but yeah, it was really fun. Yes, and then it was very nice. Well, she was so good. She had a huge repertoire, like.
Good morning, everyone. If you can take your seats so we can start our session.
Before we start, actually, we're in the home stretch here, guys. This is the last, one of the last sessions in the main room here. And I just want to take the opportunity to thank the Sarnicola family for another successful SICSSO meeting. There's a lot of work that goes into this meeting that's truly evident. Very proud to see how the meeting has grown over the years. So a true heartfelt thanks to Enzo, Enrica, Francesco, and everyone involved in the meeting. So this morning's session is on cataract surgery and challenging corneas. I'm Terry Kim. It's a pleasure to moderate this session along with my panelists, Guillermo Rocha, Mark Terry, and Josh Teichman. And we have a series of lectures. I think what we'll do is, there's plenty of time, I think, so after each lecture we'll have a little discussion on the topic. Happy to have any of you in the audience ask some questions. And then if we have time at the end, we'll have some overall discussion, Q&A about the general topic. So without further ado, I'll call up Michael Snyder from the U.S. who's going to talk to us about cataract surgery and zonulopathy. Thanks, Mike.
Thank you so much. It's really a pleasure to be here. Thank you for including me. Zonulopathy is a passionate topic for me. I really enjoy these cases. I do want to acknowledge my relationships with industry partners, without whom we wouldn't have all the things we need to get things done. So sometimes zonulopathy is an across-the-room diagnosis and it's super obvious. There's other times where we're just suspicious based on various historical or exam findings. And the progressive zonulopathies, I think, are special. One of the challenges with progressive zonulopathies is you don't know whether they're there yet. Sometimes you do, but sometimes you don't. And so one question that I always like to challenge myself with is, what do we do if there is no zonulopathy yet, but the patient has a longer horizon? And for the progressive zonulopathies, I've answered this question by saying, yes, I do place capsular tension rings, not because it's going to reduce the chance of a zonular dehiscence later down the road, but if this patient shows up in my office and I see this CTR in the pupillary space, it's much easier to fix than if there is no ring in place. So I do it to make my job easier later down the road, and that's what I tell my patients. There's two progressive zonulopathies that I like to pay special attention to. Anytime I see somebody in my office that has a zonular dialysis for no apparent reason, I want to rule out Marfan's and I want to rule out homocystinuria. Why is that important? Well, number one, it's an opportunity to save a life, and ophthalmologists don't get to do that every day. So it's kind of fun. So if you have somebody coming up into your office and they look like a Marfan's patient, worthwhile to go ahead and get an echo. And even if they don't look like a Marfan's patient, go ahead and get an echo. It's cheap, it's inexpensive, and if you catch an aortic root dilation before they develop a dissection, you can save their life. Similarly, I always like to think about homocystinuria, because homocystinuria is very, very common, but very, very underdiagnosed. And these patients, if you get a serum test, it's very easily treatable. And if you ask these patients, hey, by the way, do you have any early coronary artery disease in your family? Oh yeah, 2 brothers who died in their 40s. Go ahead, get the lab test. It's cheap, it's easy. All zonulopathy patients might save a life. So I'm going to review a few video-based tips here, and I hope you find them helpful. This is a 4-year-old with Marfan syndrome and an amblyogenic subluxation demonstrating viscotamponade so that we can prevent the exposed hyaloid face from coming into the anterior chamber. Always like to use dispersive OVD for the tamponade. Sometimes the vitreous is already in the anterior chamber, in which case we must remove it before we start doing any other manipulations. I prefer a pars plana incision for my port, and we're going to stain the vitreous using dilute triamcinolone. We wash it away a little so we have a little better view. And then my preference is to have anterior infusion with posterior cutting so that we're creating an anterior to posterior pressure gradient. And then once the gel is all removed, we use our dispositive OVD tamponade and continue along with the case. Capsulorhexis is the hardest part with any zonulopathy case because we don't have normal countertraction, and often it's in younger patients. So for example, in this 4-year-old, we used some trypan blue. Burkhardt Dick has shown us that trypan blue applied for 30 to 40 seconds can markedly reduce the zonulopathy, markedly reduce the elasticity, making capsulorhexis and zonulopathy more facile. Sometimes, even with tripe and blue staining, we can't pierce the capsule with a cystotome, so two opposing 30-gauge needles in a cross swords approach will always work. And then we can start our peeling at whichever one opens first. In this case, we find that we need to create a little bit of counter traction on the capsulorhexis margin, so an iris hook is used to pinch that margin a little bit so that we can peel around the capsulorhexis in this very, very tiny lens. Also, we're of course using retractors to allow our view so that we don't get caught up in the zymus, and eventually we're able to complete it. Another way to achieve the same counter traction is using one forceps to hold the lens in place while we use another forceps to peel using multiple paracenteses. You might wonder why I didn't put iris hooks in here first. We know we're going to need capsule hooks for this case, and so why have 8 openings when we can have 4? We add those later. So during the phaco, there are several devices we can use to help support the capsule. For a young patient like this, we use dispersive OVD to stent the capsule open, and then we can simply aspirate the implant lens in front. In other cases, we need to use a mechanical stent that supports the equator of the capsular bag. These Chang capsular hooks are super helpful, and they support both the capsulorhexis and the equator, and then we can use our usual techniques to evacuate the remainder of the lens in a normal fashion. For long-term capsular support, I prefer using devices that we can fixate to the scleral wall unless there's a small zonular dialysis. I like the Sione ring, and there are several other techniques available worldwide. Sometimes, as in this Marfan patient, the bag is so small that a large ring will not fit, but you can shrink the ring by creating multiple bends, and then it becomes much more facile. A tenonylon suture through the leading element eyelet allows us to guide the suture, and then placing the trailing element in manually. Look at how much overlap there is in this tiny little bag. We expand the ciliary sulcus, and then we retrieve these sutures in front of the hyaloid face and tighten just to maintain a perfect centration of our implant lens. In a megalo-ophthalmic case, these almost always have zonulopathy, not always apparent. We need to make sure our capsulorhexis is small. Did you guys see I forgot to put OVD in before filling the chamber when I took my instrument out? I got away with it, but just because I was lucky. The posterior capsulorhexis is important in this case too, because the bag is larger than the implant lens and the capsular tension ring. So we're going to enlarge our capsular tension ring, but it now only covers 8 clock hours. So will one ring do the job? I think not. Once we have it secured in that one in position, we will add 2 segments and give ourselves a tripod fixation. To fixate the implant, which is larger than the bag, we've captured it through both anterior and posterior capsulorhexis. We can also use an in-the-bag iris device and center that as well using a capsular tension fixated Sione ring. For smaller bags, we can place a small capsular tension segment, and in this particular eye, we would in no way be able to fit a large ring in there initially. Notice as we increase the tension and then we peek behind the iris, the segment is tilted about 60 degrees anteriorly. That's not a great long-term solution as it can potentially pop out of the bag. So we will place a second ring in with the Sione fixation element, and once the second ring is manually placed and fixated next door, then we're going to be able to reduce some of the tension on that initial ring. Now, why is it important? Isn't the CTS and the CTR all the same thing? Not really. When we look at the physics, a capsular segment only covers 120 degrees apart. And as we apply tension to our suture, the fixation element is centripetal to the axis of rotation, which is really at the zonular equator. And if we look at the force, the more the moment arm, the more the torque. So here there's a very low moment arm and very little torque, but as soon as we put some tension on, the torque increases, the tilt increases. The torque increases more, the tilt increases more, the moment arm increases more. And this keeps happening, and eventually you get to a point at which, if the moment arm is strong enough and the tension is too high, the segment will pop out of the capsular bag. Ask me how I know. It's a very unpleasant experience. So if we use a single ring that is all in one piece, like the Sione rings, the opposing side of the ring creates a counter torque with a huge lever arm, and so we don't have any tilt problems, and the device will always stay within the capsule bag. Another solution is to use a fixation element like the Cana Brava segment, where the fixation point is peripheral to the capsule, thus obviating the tilt and torque. Similarly, the Aussie anchor, its fixation element is peripheral to the equator of the bag, and again, obviating the torque. IOL should always be placed within the capsule bag once the bag is stabilized. Placing a sulcus implant in the setting of zonulopathy is looking for the opportunity for a late subluxation, and it will always find its way out. So, conclusions, whenever we see zonulopathy, don't forget to save a life when you can. Get an echo and get some labs done. It's worth preserving the bag. We have more implant lens options, and we can hopefully preserve the highlighted face and limit the manipulation of the vitreous. And we've got lots of tools available to us. Thanks so much for giving me the opportunity to be here today.
Any questions for Dr. Snyder on this? Go ahead, Dan.
Yeah, I loved your last slide about zonulopathy, because there's this whole thing about putting three-piece lenses, sulcus optic capture in patients with zonulopathy, and saying that it's stable. Can you talk a little bit about that and how, because I don't do that, and it just doesn't theoretically make sense how it would stay stable.
Yeah, so if you put in a three-piece lens and you trap the optic within the capsulorhexis so that the optic is in the bag, well then the optic is being stabilized by the bag. And the optic therefore is helping. But the haptics aren't providing any valuable support. The challenge is that when you've got more than a trivial zonulopathy, it's very difficult to capture the optic into the bag. And so if you fail in that maneuver, now you've got this lens that's sitting there. And what often happens is people will say, oh, well, it's a three-piece lens, I'll just leave it in the ciliary sulcus. And then eventually it finds its way out of position and finds its way into my office, and it's super frustrating. It's very difficult to trap the optic into the capsulorhexis, and it's very difficult to get a three-piece lens into the bag when you have a zonular dialysis. So my strong preference is one-piece lenses in the bag and stabilize the bag by other mechanisms, but I know it's a bit of a controversial topic. I'm not sure why.
Yes, Mike. What is your take on dead back syndrome? Where does it come from? What should we do? Why are some people seeing a lot of it and others not so much?
Yeah, great question. And I'm glad Steve Saffron's not in the audience because he starts to twitch whenever I talk about this topic. We have differences of opinion. So I think dead bag syndrome is very complex. I don't fully understand the mechanisms behind it. I see very little dead bag syndrome in my practice. And I've been around for a while, so I should see a little bit more. I should be seeing people that I'd operated on years ago coming back. I am not overly aggressive in polishing lens epithelial cells. And I personally think that dead bag syndrome may have a correlation, not a causation, but a correlation, because the bag is collagen, it's type 4 collagen. Type 4 collagen is basement membrane material. Basement membrane material likes to have adjacent cells. And when it loses adjacent cells, basement membrane material degrades in other parts of the body. Why should we think that it does not in the eye? And so I think if we use that teleologic thinking, that the more we are aggressive in removing lens epithelial cells from the underside of the capsule, perhaps that may increase dead bag syndrome. I don't know why it always happens in every case that it does. I've seen patients where I have not polished lens epithelial cells, but I definitely see it much less than folks who are avid polishers.
We see a lot of, thank you, it's a beautiful lecture. We see a lot of patients with pseudoexfoliation in Northern Europe. What is your point of view on using multifocal IOLs in these patients, given the risks for progressive zonulopathy?
Why not? If you put a capsular tension ring in the bag, first, if it's a patient with a super long horizon, you can go ahead and put in a Sione ring at the time of surgery, put in a suture at 12 o'clock, and then they're never, ever, ever going to have a problem. If they've got an intermediate horizon and you place a standard ring in the bag when there's no zonulopathy, then as soon as they start to shift a little bit, you can throw 1 or 2 or 3 sutures around the equator of the capsular retention ring, solves the problem.
One question, is that usual?
I'm a little conservative on using simultaneous fishing lenses in patients with sodium exfoliation, but even if there is no zonulopathy, patients have described as like sodium exfoliation from marathons. I've got very low threshold of going in immunoprophylaxis here.
So, quick question to end on this section. For the scenario where you don't have enough support to actually save the bag, how many of you are using Yamini technique to fixate a lens in the absence of a capsular bag? Just curious in the audience, Yamini fixation. So, okay, great. Obviously, we know there's some limitations with that technique. I just want to put in an unsolicited plug for a device called Lens One, Lensone by Longbridge. It's unsolicited plug by Frank Brody. It will go into clinical trials this fall. But it's a silicone device, prosthetic capsular bag, 3-point fixation that you can put any lens into. So look out for this device because I think it's going to be a game changer. Yeah. Okay, we're going to move to the next topic more. If you can get up to the podium, Dr. Moore Dickman's going to talk. But thank you very much, Michael. That was a great overview on the topic. We're going to switch topics and address toric eye wallets and keratoconus patient selection and eyeball calculation. Thanks.
Yes, thank you very much. It's a pleasure to be here today and speak about cataract surgery and IOL calculations in keratoconus at the British presentation together with my good friend and colleague, Ali Abulafia. So today we know that the benchmark standards for refractive outcomes after cataract surgery are hanging around the level of 80% in eyes with 0.5 diopters from the intended refraction. So in some clinical settings, it could reach around 90%. However, we know that in patients with keratoconus, our prediction accuracy drops quite dramatically, and this is why keratoconus forms its challenge when also combined with cataract surgery. In 2019, Savini and his group showed that using standard formulas in eyes with keratoconus will result in a hyperopic prediction error with relative low prediction accuracy, and that both get worse depending on the severity stage of the keratoconus. They also showed that the SRKT formula had the highest prediction accuracy as compared to other standard formula that were tested, including the Barrett Universal 2 formula. So why is it so hard to predict the refractive outcomes in eyes with keratoconus? It's a combination of factors, and I think the main challenges include, first of all, difficulties in obtaining accurate corneal refractive power. Such as the symmetry of the corneal curvature in the posterior to anterior corneal curvature ratio. No longer what we expect in normal eyes, and it we are still not perfect with that, and I think this is one of the main challenges that we have. And here's an example of some of the devices that we currently use. Other challenges include predicting the effective lens position, because most formulas rely on the corneal power for this purpose, and we just saw that it's difficult to measure this. And difficulties of obtaining reliable post-op refraction, because these corneas are actually multifocals. And I think this is one caveat when evaluating many studies, that we can't really rely on our outcome measures, which is the refraction in these eyes. So today we have 3 designated formulas for eyes with keratoconus. We have the Holiday Consulting software, we have the King, and we have the Barrett 2K. And the Barrett 2K is unique because it has an option to utilize direct measurements of the posterior cornea. Unfortunately, the published data regarding their prediction accuracy is limited. So here we look at the results from Keynes in 2020. Keynes and his group compared the prediction accuracy of standard and two designated formulas for keratoconus. That's Keynes and the Holiday 2. And they found that Holiday 2 with the keratoconus adjustment had only 27% of eyes with 0.5 diopters, with 0.5 diopters from the intended refraction, whereas the Keynes keratoconus had the highest prediction accuracy with 50% of eyes within 0.5 diopters. And I remind you that in normal settings you would expect around 85% of eyes to have this, and in expert settings about 95%. Then we go over to Tom and her group, who looked at 32 keratoconus eyes from 23 patients who had toric IOL implantations, and they showed that the Barrett True K with direct measurement of the posterior cornea had the highest prediction accuracy of 88% within 0.5 diopters, followed by the True K predicted posterior cornea with 78%, whereas the SRKT and the Keynes keratoconus had 59 and 53% predictability respectively. So we conducted a study in order to examine the accuracy of intraocular lens calculations in eyes with keratoconus, and we specifically focused on different formulas, but also the predicted versus calculated posterior cornea with the Barrett True K. In our study, we included 57 eyes of 57 patients, and we found that the Barrett True K with the predicted and measured posterior cornea had actually similar prediction accuracies of 71% and 72% within 0.5 diopters from the intended refraction. And they were significantly more accurate than the standard Barrett Universal 2 and the Keynes formulas, but not from the Keynes keratoconus and the SRKT formulas, which had 60% and 58% within 0.5 diopters, respectively. So two more papers that were published in the same year. The first one is from JRS, which shows that using the keratoconus-specific formulas in the SRKT with the Wing-Cock adjustment improved the prediction accuracy compared to other formulas. And the second one's in AGO that stated that the Barrett True K with a measured posterior cornea performed best, but with only 46% of eyes with 0.5 diopters from the intended refraction. So many of our keratoconus patients have significant corneal astigmatism, and another issue would be, because until now we focus on the sphere, should we implant toric IOLs in these eyes, and which patients will be most suitable? This is quite a controversial topic, because the ideal candidates are those with mild to moderate keratoconus with stable disease, satisfactory vision with glasses prior to the development of cataract, no central corneal scarring, and contact lens intolerance. If you decide to implant a toric IOL calculator, it's very important the use of toric calculators with standard mathematical models should be avoided because of their internal algorithms are based on the predicted posterior corneal astigmatism, which is true in normal eyes on average, but is not designed for this purpose. So don't use these calculators for eyes with keratoconus. One can use the Keynes toric calculator for keratoconus, or a toric calculator that uses measurements of the posterior cornea, such as the Barrett calculator or the Edo toric calculators, but just remember to ignore their spherical equivalent prediction, which we just showed how to calculate. Okay, so I'd like to finish with two cases together. The first case is a 73-year-old patient with keratoconus and cataract that was scheduled for cataract surgery in her left eye. Here are the topography and tomography axial maps of her left eye. And although one can consider to implant the toric IOL in this case, she was happy with her scleral contact lenses prior to the development of the cataract, and was happy to keep it after cataract surgery. In those patients, I do not consider implanting a toric IOL. So here we see what surgery was done and what are the outcomes. I used the true K in order to calculate the spherical equivalent. And after surgery, the patient is using scleral lenses and achieves 6.75 vision, which is quite good. She's happy. However, in the second case, this lady does not want to use contact lenses and really wants to have a toric IOL. So similar to patients following refractive surgery, what I do is I look for a relatively regular bow tie corneal astigmatism, specifically within the 3 millimeter central zone. And I consider differences of 50 degrees or less in astigmatism between the different meridians in 2 ocular biometers, differences of 0.75 diopters or less in corneal astigmatism magnitude with 2 ocular biometers. And I'd like to use the integrated K values from the Barrett toric calculator. So basically we have quite a lot of variance with measurements, and we'd like to reduce that. And we'll reduce the variance in measurements by looking at the median value from measurements from at least 2 different devices. And that's something that I'll recommend you to do. Okay. Here are the results from the different biometers. With the Ken and the Barrett toric calculators, we can look at the results from both of them, and also don't forget to look at the old glass prescriptions, just for reassurance that we're more or less on the right track. And that's a glass prescription before they developed their cataract, of course. Then I look at the prediction range for the Barrett True K formulas, the SRKT and the K, and the prediction errors. And then make a choice. This case turned out quite nice, otherwise I would not have shown it here today. Sorry. So what are the take-home messages to finish about? We know that keratoconus eyes pose difficult challenges for IOL power calculation. It's very important to use several measuring devices and IOL power calculation formulas. Toric IOLs are suitable, but only for a select keratoconus patients who do not wish to use contact lenses and have regular astigmatism, which is moderate to mild, not very severe. And patient counseling is critical. It's better to under-promise and over-deliver in these eyes, because results, even with best of hands and calculations, remain quite unpredictable. And Sardinia is beautiful, but also want to invite you to visit our beautiful city of Utrecht in the Netherlands. Thank you very much.
Thank you. Great talk. Any questions for Laura?
I have a comment. I thought that was an amazing talk. I think it's, the way you presented it in terms of what to do for toric lenses was excellent. The other thing I've been doing differently recently is actually doing CTAC initially in these keratoconic patients to regularize the cornea, and it's allowing me to actually do more toric lenses in patients who want to be contact lens independent. So that's also been another excellent addition.
So Claudio and Bruno Trindade in Brazil have shown some really great data using toric implant lenses with an overlying pinhole implant in keratoconic patients. The pinhole implant has disappeared from the European marketplace, but I understand will be reappearing shortly. Do you think that that will have a place, and will you hope to incorporate that here in Europe? And of course, those of us in the US might have access to it in 25 years.
Well, first of all, I think that, well, I would reserve, this is not something I standardly use. I think the order is, even my residents, when you follow this order, it becomes very much more easy and structured to calculate lenses in keratoconus. So it's something that we also teach our residents. You start with the sphere, then you go to the toric, you do it separately, you use several biometers, you use several calculation methods, and then we reduce the variance by using the tools that I've shown. I think to your question, the pinhole device is something that I would consider only in highly irregular corneas. And that's beyond the scope of my current lecture. I believe that it would not be fair to reduce patients' peripheral visual field, to limit our ability to evaluate their retina or glaucoma, etc. So that's not something that I would consider in mild and moderate and even severe, relatively regular keratoconus patients. Only to those post-transplant transplants, and with CTAC, I don't have experience yet calculating toric IOs after CTAC. I think that's a new and interesting area to look at. What I would be curious to know is what is the long-term predictability of these methods, just as well, which is also a limitation that I always speak with patients who have underwent a transplant before, either a TKP or a DEL, that there is always a risk that you'll have to take the implant out, or that the refraction will change, but that the IOL will stay there. And in those patients, I would be very weary on putting a toric IOL if they don't need a scleral lens before, they might not need one later either. So.
And we do have the ICA in the U.S. as a first question in the back.
Thank you. Thank you for your talk. I have some question about calculation. First of all, when you decide for a toric IOL, do you consider all the axis, both the axis of the astigmatism and the coma, and do you consider K1, K2, one with zone 3 mm, 4 mm, or for example MPP in MS39?
So which to repeat the question, which parameters are most important for calculating the toric
the axis of the coma, and if it is coincident with the axis of astigmatism, first of all?
No, I don't consider that because it's also not a factor that's taken into consideration in all the calculators. I think the whole talk is you need to understand what are the calculators using in order to achieve a certain outcome, and what are the caveats that are specific to keratoconus that you need to consider while you're using them. And coma is not one of them. Coma is something that I do consider when we want to do a topo-guided PTK treatment for these patients, but it's not something that I use in calculating toric IOLs. In toric IOLs, I look at K1, I look at K2, I look at it from two different devices. I look to see how repeatable they are, what is the difference between the different devices, and I look at the median of those measurements in order not to make it too big of a mistake. And I think the key thing is when you have all these measurements from different devices, different calculators, and the median, you need to always look what is the worst case scenario. So you want to make sure that you get a lot of deviation between all of those. And for example, what you wouldn't like to do is make these patients hyperopic. They usually do not appreciate that. So if one of those options shows that direction, that's something that I won't take because I'd be happy to err on the myopic side. I think another common mistake is using these calculators which are specific to keratoconus and then choosing a myopic target, because then you're doing two times. You're doing 2 times the correction, and then you might end up quite myopic. So when using these keratoconus specific calculators, I try to achieve ametropia for the sphere. I hope this answers your question.
Thank you.
Which zone do you use for a K1, K2?
Well, it depends on the cornea. If I look at, for me, it's the 3 mm central zone. If it's more regular there and irregular outside, I might consider doing it based on 3 mm zone.
Yeah. And maybe one last question from...
Yeah, no question. Just I have few patients in this case. First, regularization of cornea is more important than anything. I take into account aberration. If I have coma, I have high aberration, I have to regularize first my coronary cares. And when I have practice cares, in this case, I enlarge the optic zone. I never go under 5 mm. And 3 months after my care surgery, I can calculate with a precise biometry my spherical IOL.
So I think what you're saying is very important. You're saying that some keratoconus patients could benefit from regularizing the cornea before undergoing cataract surgery, which will open more options also for toric IOLs.
Yeah.
It's just that I don't have any data on this right now, and this should be a very interesting topic.
Yeah.
The second point that you raised, which is very important, is why is CARES working so nicely? It's working so nicely because the pupillary zone does not contain an interface with tissue, which would otherwise probably be great vision. It's outside the pupillary zone, and that's the very
never go under 5 mm because after it should be very difficult to calculate your IOL.
Great. We have to move on to the next lecture. Thank you, Moore. I'm going to call up Dr. Satish Srivastava from UK, who's going to talk to us about corneal issues and cataract surgery.
Thank you, Terry. Good morning, everybody. Many thanks, Dr. Sarnicola and Professor Vincenzo for the kind invitation. I've been asked to talk about corneal issues and cataract surgery. This is quite a broad topic to cover. We've got issues of the surface, corneal scars, corneal cutaneous fugues, and surgically compromised corneas. I'm going to be, given the time restrictions, I'm going to be sticking to the first two topics. My next speaker will be going to talk about fugues. So one of the common issues we come across in patients with cataract surgery and corneal susceptibility with the ocular surface disease. This is a patient of mine with ocular pemphigoid or mucous membrane pemphigoid. And these patients are very important because they have underlying immune modulation disease. They always have an activated complement system, which increases the vascular permeability of the ocular surface, and which means there's increased neutrophils being present, and this can infiltrate the peripheral cornea. And any surgical trauma will amplify this, and will increase proteolytic and collagenase enzymes, which can result to corneal blood. So this is a patient, the same patient I showed you on the first slide, who underwent an uncomplicated cataract surgery, and within 4 weeks, about 4 millimeters from the corneal, superior corneal incision, she developed peripheral ulcerative keratitis. And this was subsequently treated by increasing her topical steroids, which is non-preserved, and also increasing her systemic medication. So it's very important to, even the eyes are very quiet, it's very important to consider these patients have always upregulated immune driven process, and any surgical intervention during cataract surgery will upregulate the inflammatory process. This is another patient of mine who had rheumatoid arthritis and severe dry eye, and was referred to me with my colleague with cataract surgery, which was totally uncomplicated, but these patients were all put on preservative topical steroids and also preserved non-steroidal anti-inflammatory medications. So 4 weeks after an uncomplicated cataract surgery, she comes in with almost desmoidal and threatening proliferation, which was very well managed by changing medications. So one of the important issues to consider during cataract surgery is to protect the epithelium, especially these patients. Constant exposure to microscope light can desiccate the epithelium, and these patients can quickly lose their epithelium, which can upregulate the inflammatory process. So reducing the microscope light during cataract surgery, protecting the epithelium with OVD continuously during the entire procedure will help to improve the surface. And also it's very important to optimize the ocular surface with unpreserved topical medications before, during, and after surgery. Very important to understand that these patients need to be treated with pre- and perioperative oral or topical steroids. And very important to avoid non-steroidal topical postoperative drops, and also to use only preservative-free medications during the postoperative period. And protecting the epithelium intraoperatively also helps. So next thing I want to talk about is corneal scars and cataract surgery. This is a very common occurrence in my practice, especially if you're doing cornea and cataract in your practice. You're going to see a lot of patients with corneal scars who will be needing cataract surgery at some point in their life. This is one of the patients with mild corneal scars. As you can see, it's got a good red reflex. Once again, it's a counterintuitive not to increase the illumination of the operating microscope, because more light from the operating microscope is going to scatter light from the corneal scar, and it's going to decrease the view. So some of the practical tips would be to reduce the operating microscope light and also switch off the operating room light so that you have a better contrast on that. And once again, covering the epithelium with OVD and putting a little bit of BSS improves the view, and this could be constantly done during the entire process of the cataract surgery. Even if you get a good red reflex, I would recommend using trypan blue, which sometimes helps to find the margin of the capsulorhexis, and once again tilting the patient's eye, or by tilting the microscope will help to negate the scar and find you a good margin to produce an uncomplicated intact capsulorhexis margin during cataract surgery. This is another patient of mine with a partial limbal stem cell disease, very sick-looking corneal epithelium, having cataract surgery. Once again, you start the cataract surgery process just with being a dispersive OVD, and if you just put a blob of PSS on the top of the OVD, that kind of smoothens the surface, and it gives you a better intraoperative view. And once again, I always use trypan blue. Even if it's a good red reflex, it always helps me to delineate the capsulorhexis margin as we proceed. So we stain the capsule, and then we constantly have this OVD protecting the epithelium. And then we start off with the incision, and once again OVD to deepen the anterior chamber and get rid of all the bubbles so that you have a better view. And this time we have switched off the operating microscope light and just using it as a single-use endo illuminator on my non-dominant left hand, just press with the capsule at the paracentesis margin, and that gives me a better intraoperative view. Just we use this device to initiate our capsulorhexis. The operating microscope light is completely switched off, and also the room light is completely switched off in the operating room. So now we have got the corneal scar is taken away because we've got the endo illuminator directly illuminating the anterior chamber from the paracentesis, and that gives you a very good view to do your capsulorhexis. Sometimes it's useful to take a patient for a dry run. This is a patient I'm just doing a dry run, bringing him into the operating room, just putting a speculum, and then he's just going to, this is the patient I'm planning to operate, but this time I'm just doing a dry run, bringing the patient. This time I'm using a chandelier endo illuminator just to have a dry run to see whether I can perform the surgery. This kind of planning helps so that you don't have any intraoperative surprises. This is a patient with a herpetic severe stromal keratitis, healed with severe vascularization, or also had a herpetic uveitis and iritis. You can see iris stromal loss, severe posterior synechiae, and a corneal scar. Can you play that video? Doesn't want to play. Okay, so same principle of protecting the OVD, using Malugan ring to stretch the pupil, removing the inflammatory fibrin membrane from the anterior capsule, vision blue for capsulorhexis, and using a side port endo illuminator for capsulorhexis margin. This is a patient post-operatively has done well. This is another patient who had previous PK, now coming in for cataract surgery. Once again, the same principles which I've talked to you about, protecting the OVD, using vision blue. And this time, because I need to use both my hands, we're going to use a 25 gauge chandelier endo illuminator, 2 paracentesis like we use for iris hooks. And these are chandelier endo illuminator devices which helps you to give you a hands-free option of illuminating the anterior chambers. Once again, same principles of switching off the operating microscope light, switching off the operating room light, and all the corneal scar and the play of the corneal scar is taken away because now we have got a light pipe beautifully illuminating the anterior chamber, and it's a hands-free technique. So this helps me to do my capsulorhexis, this helps me to do my nuclear disinsertion, and also gives me the depth of the crack, which also helps us to keep the posterior capsule well away from the zone. So once again, you can see the beautiful illumination of the anterior chamber. Once this part is done, we take off the chandelier system off, operating microscope light is back on. Now we have got the red reflex from the posterior segment, where I could safely do the irrigation aspiration and implant the iola of choice within the capsular bag. This is another patient where we are going to do a PK and a cataract surgery. Patient has got severe subepithelial corneal scarring. So we are starting off doing a superficial keratectomy to remove off all the swollen epithelium. And you can see a very dense stromal scar. We are going to mark the center. We're going to use the Hannes-Trepfine to partially trephinate roughly to about 200-250 microns, so that I've got a partial trephination groove into the cornea. And once again, the principle of this is not to do an open scale cataract surgery, but to do a closed chamber cataract surgery followed by the PK on the top of it. So once again, I've made the partial trephination of the cornea, same principle of putting OVD to protect the epithelium and to improve my view, vision blue to stain the anterior capsule, and we're doing a posterior limbal incision about 2.75, and then we're going to use the endo illuminator once again to initiate the capsulorhexis with the tricangular stain anterior capsule. Once again, it gives you a good view, and then we finish off the capsulorhexis. And once again, I constantly stop during the process to make sure this process is very stable so that I get a good view. And then we start off trying to see whether we can groove this through the corneal scar. Halfway through, I realize the view is very bad. So once again, we go back to using the chandelier system. And this is all done in a closed chamber, no open sky, so you have got complete control of the process. So you're putting two 25 gauge chandelier light bulbs. I'm sitting superiorly, these are all inferior quadrants. Now it frees up both my hands. I'm right-handed surgeon, so I use my phaco multiplication device with my right hand, and the second hand, I've got the second instrument, the SICSSO, which is going to help me to do this in a controlled fashion. And you can always tilt the chandelier as you go through the process, so that you can know where the posterior plate of the cataract is, and it helps you to give you the good depth and makes this entire challenging case much more easier and palatable to do because you've got a much better wide field illumination within the anterior chamber. So once this is done, if the view is continuing to be very cloudy, I will continue with the chandelier system. If not, at this point, I'll switch off the chandelier system and then go back to the operating microscope light. Once again, I'm using bimanual IA now, and I've got a hands-free 25 gauge two chandelier light pipes, which is helping me to illuminate the entire anterior segmenting between the capsular bag. Once the phaco multiplication is done, the chandelier light pipe comes off. We've got a 3-piece IOL going into the capsular bag now. And then IA to remove it. And then now we are going to suture the posterior limbal bone.
And Satish will probably have to have you wrap.
And then we are doing a manual top hat dissection. So I've run out of time, so I'll just stop here. In patients who have got severe corneal scars following superficial keratectomy, we were unable to do any measurements for cataract surgery because of the irregular corneal scar. This patient underwent a femtosecond laser-assisted superficial anterior lamellar keratoplasty of 250 microns. That's the scar removed. And this patient had a 250 micron superficial anterior lamellar keratoplasty with femtosecond laser, and they are done well. So in the interest of time, I'll stop here. So these are the take-home messages: optimize your microscope illumination, coat the ocular surface, tilt the microscope, and consider using anterior segment illumination. Thanks.
Thank you. Great technique. We're going to save the questions so we can get in, last but not least, Zaina Almatzev's talk on premium IOLs and future patients. And if there are a few minutes after, we can throw in a few questions. So, without further ado, Zaina.
Thank you so much, Terry. If we can bring up my slides. Okay, for me, yes, perfect. So let's talk a little bit about trying to be able to do premium IOLs in patients who have Fuchs dystrophy. Can you do it or can you not? Really, the issue is IOL calculation and the refractive outcome. You know, we know that in general you get a hyperopic shift, much less than with DSEC, but there is a variability in these patients. The higher order aberrations do decrease, but they're still higher than a normal patient. And so in general, we target about minus 0.5. So what about toric IOLs and DMAC? There's been some studies that show that there's an improvement in uncorrected distance visual acuity. You can decrease the astigmatism correction in this study, but there's misalignment that can happen, especially technically speaking, when you do a toric IOL, then you put the gas bubble. You really don't know where where it ends up in terms of the axis. So this is a patient that has Fuchs dystrophy and significant astigmatism. And what I did in this case is, you know, you can look at the topography, especially with corneal edema. The topography is always very difficult to assess in terms of the astigmatism measurement. You can see that there's corneal thickness, everything else is normal. So what I did is DMEC first in these patients. So greater than 2 diopters of astigmatism, waited about average of 3 months post-DMEC. I did it about a month apart in each of these patients. And then I proceeded with the toric lens placement with a significant change in the magnitude of astigmatism and the axis of astigmatism in these patients. And post-operatively, this patient did very, very well. So what I do for patients who have significant astigmatism, if it's greater than 2.5 diopters, I actually do the DMEC first and see where everything ends up. This is post-operatively how the patient did. Anything less than 1.5 diopters of astigmatism, I actually err towards a light adjustable lens because I really can adjust it post-operatively. You could also do LRIs in these patients post-operatively after the cornea has stabilized. I just don't think with greater than 2.5 diopters, I could successfully have an excellent outcome every single time I do toric lenses in these patients. What about multifocal IOLs? I'm a pretty conservative surgeon. I do not place multifocal IOLs in patients with DMEC because, like I told you, the concept of the higher order aberrations and the refractive tolerance. Again, if you are trying to hit your multifocal IOL, you really need to have less than 0.5 diopters of astigmatism and then pretty much a spherical equivalent of close to 0. And that's not very easy, but I'm very comfortable doing extended depth of focus, again, in these patients. But there are patients that have been sent to me with multifocal IOLs that have done DMEC. So I want to talk a little bit about that. This is an example of a patient with a Tectus multifocal who was really happy with his distance and intermediate vision, but over time has gotten blurry because of the swelling of the cornea. And you can see the left eye is doing worse than the right eye, but both pretty significant. I did DMEC in this patient. The right eye did very well. The left eye could never really get better than 20/40, maybe 20/30 with correction. And again, in this case, if you look, it's really the higher order aberration profile. Cornea was doing really well, but the multifocal. But the patient was happy. So it really goes back to, what the patient wants at that moment, what the patient wants, years later. But in general, I would not primarily place a multifocal lens in a patient that has Fuchs dystrophy. And even though these patients do well, there is a difference with their outcome in terms of the quality than patients who don't have Fuchs dystrophy. But this is really where I want to concentrate on. This is a patient that has Fuchs dystrophy and a cataract. And again, this is the photo with the guttata, and just showing that they have pretty thick corneas. And then again, this is the IOL master showing less than 1.5 diopters of silk, because that's an important element in the patient if I'm going to do the light adjustable. So for patients who want more refractively, when I do DMEC, I actually do combine with light adjustable lens. What's nice is you can do the surgery at the same time because you can adjust post-operatively. And I target about a -0.5 in these patients. One thing, this takes a very long time for stability. What you can see here, on average, I wait at least 3 months post-DMEC surgery before I consider doing optimization and adjustments in these patients. So you can see this patient I did in December didn't really finish with everything until April, May in terms of the post-operative adjustment period. But these outcomes I have never gotten with any other lens in these patients. So, and this is typical. So for my light adjustable, it's called sort of more the blended vision. So type of a mini monovision with an extended depth of focus with each of these lenses. And so for the dominant eye, 20/20 J2, maybe J3, and then the left eye, again, maybe the distance vision isn't as clear, but really getting that J1 plus outcomes. And these patients do very well. Post-operatively, you can see the corneal thinning after the DMEC. And the reason for this is it's really for patients who are motivated to be glasses independent. This is the way I can get the refractive outcome that they want, but you have to tell them, again, 6 months that you're waiting, wearing these sunglasses outside. It is not this is not for the faint of heart in terms of doing it. And you can see here accuracy, 93%, 81%, really within 0.5 diopters and 93%. This is looking at my data of our first 14 patients that we did. And what you look at in terms of after a lock-in, basically the average uncorrected distance visual acuity in the patient in the eyes that were for distance were about 20/20. Because it's an extended depth of focus lens, we're getting about J3 even in that distance corrected eye. And then in terms of the uncorrected visual acuity for reading in the non-dominant eye, you're getting an average of about J2, and maybe you lose a line of vision about 20/25 in terms of that outcome. And so, the most important part, and we talked about this a little bit with keratoconus and potentially doing toric lenses, is, the refractive variability after EK. You don't know where it ends up clearing. And when we say, yeah, on average, it's less than 0.5 diopters, that's not the case for some of these patients. So the only way that I can give them a refractive outcome that's a little bit more guaranteed is with the light adjustable lens. I personally do not place multifocal lenses with diffractive optics in these patients. Very comfortable with extended depth of focus lenses, with the light adjustable lenses, and even with the light adjustable lens, it's a great outcome, but it is an investment for the patient in terms of the time for the adjustments, but in general, getting the outcomes that you want. So caught up with some time.
Yeah, you did. Thank you, Zena. Couple of quick questions. I want to make sure we stay. So, for those who don't have an LAL access, right? What do you recommend in terms of the refractive target for these patients who may be getting, advanced technology lenses? And secondly, with endothelial cell therapy on the rise, and you're an active clinical investigator for Orient, what do you anticipate for us in terms of that and combining that with Canada?
Yeah, that's a great question. One is I target -0.5 in general for the distance lens. Let's say you're going to do extended depth of focus. I would target a -0.75 because in these extended depth of focus lens, it's okay to maybe have a little bit of a -0.5 myopic target for that. If you're going for plano, I would just target both eyes -0.5 in terms of the refraction if it's not the light adjustable lens. What's really exciting for me for corneal endothelial cell therapy is getting much more of a decrease in higher order aberration profile, which will allow us to actually do a much better options for lenses, and then much better in terms of refractive targeting. Because as we saw when we started with PK, and if you look at maybe 50% were within 2 diopters in some of our best trials, DSEC, again, the refractive outcome was much worse, and then we got better with DMEG. So I would say with the endothelial cell therapy, we're looking at even better spherical equivalent, better astigmatism postoperatively. It's really figuring out when it clears where it's going to be, looking at that. And I think we'll be able to use so many different lenses and better refractive targeting.
Well, that's great. It's 11 o'clock. I want to stay on time. I want to thank all the speakers for their wonderful talks, our panelists, and again, heartfelt thanks to Enzo, Enrica, the whole Sarnicola family for the success of this meeting. A lot of hard work goes in, so congratulations. And hope you enjoy the rest of the meeting. Thank you.
Chemical so I take up to 15 millimeters of imaging. If it's, say it's what do you treat? So let's say we had a unilateral, I've seen a unilateral contact only one eye. So I'm taking 2 millimeters of contrast. I only need limits for or if it's chemical injury, conjunctival disease.
Go. No, but I don't know his name.
Goblet cells, non-stem cells. So I'll take up to, I'll try to pull and see how much you get, but anywhere from 10 to 15 sugars. And then down below I only take 3 to 4 minutes. So,
but you're taking but it seems like the little it seems like a large.
Yeah, I think it was managing. Oh no, the limits itself, no. You see, he takes the caliber. So I measure 6'5", but I always take the caliber. So let's say, here's my mark, and then here's my mark, right? And then here's my mark over here. I always say, okay, I'm going to put it here, and I want this to be less. I estimate I take 40%. I always want to leave more than I take. If I have a small eye and a spinner, it's too big.
Good to see you again.
So again, if you follow the principles of code, but that's what I said. Makes no sense. This data shows 84% of the eyes you manage are chemical injuries. That is a conjunctival disease. Then he showed his eye that he kind of fixed with it, but at the same time, because he didn't. I will tell you, like in Steve Johnson syndrome, with the little the eyes actually become wet. It's a goblet cells in the and the conch stem cells, crazy. It's waiting for you. Don't do it. Conch deficiency is worse than liver deficiency. Because conch deficiency causes liver deficiency. So all Stevens Johns start with
You can.
Oh, yeah, I was going to grab you.
Please.
Another one.
Welcome. Welcome to one of the most iconic, real hallmark of SICSSO meeting, that is the life question evaluation. It's a tradition of this meeting, very, very well known and very interesting generally. So, please, Sader, yes, you are there. So, which is my wonderful panel, would be media, or less, from Ireland, Sadrianush from USA, Carol Karp will be arrived, and Slomovich from Canada. So, but first of all, I invite Catherine Colby, emerging technologist in cornea and endothelium assessment.
Thank you. Good morning, everyone. I want to echo the comments already made about what a great meeting this is. It's really a privilege to be an extended member of the Sarnicola family. I'm going to spend a few minutes telling you about some new ways we have to image the endothelium that are pretty cool. I have no financial interest, but I will be describing results from a machine that is not FDA approved for clinical use and is only used under the auspices for research imaging. So specular microscopy, we're all familiar with it as corneal surgeons. Static conventional specular microscopy, especially with the modern day instruments, does very well in the healthy eye. And there are even some versions that can reliably image out to the paracentral region, so about 3 millimeters from central. We have the Conan CellCheck 20 Plus, which is really a state-of-the-art machine, and you can see there in the orange, it says it can go out further. It's actually, in practicality, very difficult to image reliably out there. Now, this is in a normal patient. The condition, it's much different in a patient with a diseased cornea. So why do we care about peripheral endothelium? We don't see through it, you know, it's really the central one that we're really most interested in. But in this era that we're in, we're developing, and that includes the periphery. We need better imaging to answer unanswered questions. Now, it is difficult to quantify, so how do people who trained in the arrow and all we could do is penetrating keratoplasty, how do we evaluate the peripheral endothelium? You can dilate the pupil, retroilluminate, and use the high-power ocular on your Hawkstrike slit lamp, and you can get a good sense of what the endothelial cell density is and how far out the good may go. But it's challenging, and you actually have to do it. So when my residents are with me and I'm having the patient look up, look down, look over, and back, what are you doing? They're crazy ladies. Okay, so I'm going to talk to you about the CellCheck C. This is a scanning specular microscope. You can see here in a normal patient the standard specular microscope image as well as the scanning specular. And you can just see immediately from this single image how many more cells we can visualize. So this was something we did a few years ago. This was published last year in Cornea. One of my fellows, Hans, he was very proud of this. This is published in the paper, but you can see there are gaps and things like that. 2 weeks of time. We were able to show our first study with this machine. So we were the first in North America to get this machine. It has to be built for you. It takes about 6 months. It's quite expensive. We are now up to 4 machines in the United States, including ours. And one of the first things we did was show that using anatomic landmarks, we could go back to the same place in the periphery. Why is that important? Because there's only one center, but there are 360 degrees of periphery. So if you're actually looking for what is happening in the periphery, you have to go back to the same spot. So over repeated, no, this isn't a normal, repeated images, we were able to use anatomic landmarks and unique cell morphology to show that we could go back to the same exact place. So here's a standard specular and the scanning specular in a patient with Fuchs dystrophy. And you can see the standard specular, but it doesn't show us much. Maybe there's some wisps of cells, there's a lot of good type. Can't do a cell count here. The scanning specular gives you a lot more information. And we were able to show, this is a collaboration with my colleagues, Professor Beth Ann Bennett and Dr. John Lass at Case Western. We were able to show that looking in Fuchs dystrophy, which is really what we care about, both machines are excellent in normals. In Fuchs dystrophy, the CellCheck-C, the scanning specular, way outperforms the standard static specular in the moderate disease, which is mostly what we're interested in. People who have a few guttae, most imaging techniques are going to do pretty well, including your own clinical exam. But it's really in the moderate severity, which we described as Crouchmer grade 3 and 4, that the CellCheck-C really shines here, and that's important. And honestly, both of them do pretty poorly with the severe disease, but again, the CellCheck-C does better. Here is a patient of mine 3 weeks after DSO. You can see there's still some clinical corneal edema on the slit lamp photo. There's no cells visible in the standard specular, but the scanning specular, in fact, shows us that there are cells there at 3 weeks. By 9 weeks, the edema has cleared. We can image both with the static specular, and the scanning specular, again, gives us a lot more information. This is, again, a hand-stitched montage by a human of someone who is 5 years after DSO, and you can see that tram track kind of pattern. That's the actual area of the stripping. Fuchs dystrophy outside the stripped area, and within the stripped area, a reconstituted mosaic of the patient's own cells. Okay, so this is the cool thing. This was not done by humans. This was actually done by a machine. So we are now able to, in real time, have the machine analyze the individual videos and portray this on the screen. So this, for the first time, ladies and gentlemen, is the entire corneal endothelial image. It is, in this particular patient, this is a normal, these are normal anatomic landmarks that we're seeing. 64,000 cells imaged in this video. And the thing I think is really cool is at the very end, you can see we can kind of get out to the transition zone, which I think is going to be a very interesting place to look. So here you have it. We are currently doing the intellectual property disclosures for this and hoping to present it in full with the actual way we do this at the iBanking Forum in New Orleans, and publication to follow shortly thereafter. So this is normal. That's pretty cool. I showed this to my, I had to give a presentation to all the other chairs in my institution, and I showed them this, and they're like, what? Like the surgeons, the general surgeons, why is this cool? But I think you as an audience will appreciate why it's cool to be able to image the entire endothelium. Okay, this is a patient, this is an ophthalmologist with Fuchs dystrophy. And again, this is in real time, so it's no 20-minute, it's no 2 weeks of a fellow's time. The machine does this in real time, and what it can tell us is if we have missed spots, and we can go back and image. And you can see here that this ophthalmologist, so one of our colleagues, was not symptomatic, but I told him based upon this imaging that likely when he became symptomatic that I would recommend that he have cataract surgery alone and see how he does, because you can see in this higher power image that he has plenty of good cells and the guttae are not really confluent. There may be a few areas where they are, but this to me seems pretty cool. This is my initial DSO patient from 2014, so he's now 12 years out. And we did not do this in real time. This was stitched together by the program after the fact. So that's why we have the missing spot there. But again, you can see within the stripped area, an intact endothelial mosaic of his own cells, the stripped area like that tram track, and then outside of that are still the Fuchs dystrophy. So this, I think you will agree, represents a major advance in our ability to image the entire endothelium. And it becomes really important as we have all these new surgical, for example, cultured cells, and medical. There are several different approaches to medical treatment of Fuchs being developed. And I really think this is, I'm excited for that 3 of my colleagues in the US have chosen to buy this microscope. You know, they say imitation is the sincerest form of flattery, so we're hoping to have a collaborative looking at this. I want to thank you very much. I always enjoy this meeting. I try my hardest to attend, and it's always a pleasure to be with the Sarnicolas. Thank you very much.
Thank you. Now, Snyder, USA. Extirpation, iris prosthesis, and endothelial keratoplasty, a new paradigm for dual transplant.
Thank you. So this is a topic that I find super interesting. I hope you do too. I do want to acknowledge again my disclosures with industry partners. And I want to acknowledge my co-authors, as some of this data was presented at the ASCRS meeting a couple years ago. So what's the problem? Well, we've all seen this. We have patients with iridocorneal adhesions or high PAS, and their transplants fail, their corneas fail, and their repeated transplants are doomed to fail. Yes, we can try and peel these adhesions back in the operating room, and we all know they always come back no matter what we do. And so whether the failure is due to mechanical means or whether it's immune from T lymphocyte activity, it's probably both. There's good reasons to suggest that. There's at least one study that shows total iridectomy significantly reducing the risk of repeat rejection rates. And so we've taken that just a tiny step further. The other challenge with these high PAS is that if we try to do a dissect graft, it's going to push the remaining iris up against, and then we have a near inevitable graft failure, angle closure, glaucoma, and all of the potential sequelae thereof. So I'm going to present to you a case series, single surgeon retrospective group of patients who had corneal endothelial failure. Some were primary failure, some were graft failure already, combining iris extirpation or total removal of all iris tissue, a custom flexible artificial iris implant, and simultaneous decimate stripping automated endothelial keratoplasty. We had 2 different mechanisms by which we removed the iris tissue, one using mechanical extirpation with a forceps, the other using a vitrector. I'll show you both. We would then stitch in, secured to the scleral wall with 4-point fixation, a custom flexible iris device, which recreates a barrier in unicameral eyes between the front and back and allows us to perform endothelial keratoplasty rather than PK in a setting with now a recreated bicameral eye. We would then place the graft in once we've recreated that chamber. So in our initial presentation, we had 7 patients, and this is up to about 30 or 40 by now. That data has not yet been crunched. Lots of sick eyes, regular eyes don't need this kind of procedure, of course. And I've updated the follow-up a bit, and we have several grafts that are now out 3 years plus and doing well. A couple of them failed at 2 years. One of them lost a follow-up coming from a distant land without ability to access records. So I'm going to show you 2 videos of our 2 techniques. So here's video number 1. You can see there's marked corneal edema, near total iridocorneal apposition, there is an implant lens in place. There's significant subepithelial fibrosis, which we peeled off. Came off rather nicely, it's very satisfying. I agree with what others have said already today, that OBD on the surface provides significant improvement in visualization. And we take a 23 gauge microforceps, and this iris just peeled out just beautifully. It was really rather straightforward. In a very light blue and very necrotic iris, notice how we've got the fibrotic subdecimase tissue coming with that in one piece. Is very convenient and very efficient. Always a little bit of tissue stuck near tube sites that takes a little bit of extra effort. But again, it was pretty straightforward. This is a more than ample anterior segment to proceed with an untrepanated device. We put in 2 horizontal mattress sutures using EPTFE sutures. This is off-label use of these sutures. 1.5 millimeter bite, 1.5 millimeters in from the edge. We then fold the device in a trifold in what I call a conoid, meaning it's a little tighter fold at one end than the other. That makes it easier to tuck into the barrel of an injection cartridge. We put the device all fully into the barrel and all of the trailing sutures into the barrel so that the plunger does not overlap the sutures and get them snagged. We then inject the device into the anterior segment, and now we're in the process of recreating that anterior-posterior barrier. Untangling the sutures is actually the hardest part of the case many times. We're going to create sclerotomies at the level of the ciliary sulcus, roughly 4 millimeters apart. So with 1.5 millimeter gaps in our horizontal mattress and 4 to 5 millimeters externally, it gives us a tremendous degree of adjustability. Once the knots are tucked internally, we slide the device along the suture track for fine-tuning of the centration, and then we pull in our tissue through a mini boost and glide. And with the reestablished anterior chamber, we have less concern about it falling into the back of the suit. Place our air bubble to create some tension, and then I like to use a 30 gauge tip of the needle at the very edge to fully center, and 100% bubble with a happy result. Technique number 2 is that first image that I showed you, and you can see the very high iridocorneal appositions, and we can see that it's near total in most areas. And on OCT, you can see there's a slight peripheral gap. This is the only reason the patient wasn't in angle closure glaucoma. Sometimes dissecting the iris away from the back of the cornea can be very tedious. I would encourage you not to go too far peripherally. It's not too hard to create a cyclodialysis in this kind of case, and that's a very unpleasant situation. Ask me how I know. Once we've separated the entire tissue, you'll see that, and viscodissection is one of the techniques. We start off with our initial approach with a forceps, and you see that it didn't work quite as well as with the other case. We got some bleeding, so switched to a vitrector with a high infusion rate and an anterior chamber maintainer infusion. And then it's basically using the vitrector to just residually remove any of the iris tissue. It's kind of like using the paintbrush on Photoshop. It's really quite satisfying, in fact. It's rather fun. And we just move from one paracentesis to the other until we're completely away. Again, we go right up to the iris root for removing the unnecessary and damaged iris tissue. And again, not going too far. The areas of the tubes, again, is always the hardest. In this case, we had a little smaller anterior chamber than the previous one. We peeled off the failed Demek graft, and we're going to trepanate this device based on our measurements. I always like to use a metal device to press on my trephine blade in this trephine centering device. And then again, a 1.5 millimeter bite, 1.5 millimeters in from the edge. We do bites roughly 180 degrees away, and this gives us 4-point fixation for a planar device and the ability to fine-tune by having smaller bites in the device against larger sclerotomies. The device is again placed fully into the barrel, and again, all of the sutures fully into the barrel so that when we inject the device, the plunger does not catch up on any of the sutures. We don't need to worry quite as much about the endothelium in this case because, well, it's already been removed, so that's handy. And then again, organizing the sutures and keeping track of the spaghetti is some of the hardest part, and simply fine-tuning the tension on the sutures to maximize the centration of the pseudopupil with minimal ovalization. One suture was a little loose here, so we put a tack suture to the posterior sclera to just center it a bit better, removed our OVD, and again, pulling in the graft remains relatively routine now that we have a bicameral situation and a centered graft. We always make sure to tuck all the knots, cover all of the sutures, and this is a slit lamp image of that same patient 1 month out with 20/40 vision and a really compact and clear cornea. This is one that's still hanging in there after about 3 years. So I hope that you'll agree with me that combined iris extirpation and prosthesis placement along with endothelial keratoplasty is a very viable procedure for these very complex eyes. Thank you so much for your time.
Thank you. And now we have some time for discussion. Caterina, as in many other fields of medicine, peripheral doesn't mean of peripheral importance, and you show very well. In what sense do you can predict an importance of new device in directing our surgical choice?
So we are not quite at a point where we can predict which patients are better for cultured cells, DMEC, DSO. Again, this is just a research device at the current time. But, I mean, practically, if you look at this, like the ophthalmologist with the mild Fuchs, people in the community thought he was going to need a DMEC, and he was not symptomatic. And I said, just wait and have your cataract surgery, make sure it's by someone good, who's doing all the endothelial protective things that we heard about at the meeting, and see how it goes. It just gives you a much better view than even the most careful clinical exam.
Yeah, fantastic.
Can I jump in very briefly on that? So I actually came up with a clinical application while I was watching your talk. It's absolutely amazing. Thank you so much. So with ICE syndrome, we watch these patients and we all know where they're going to go, and we spend 20 years watching them go down the tubes. And it's always challenging. I think that this actually fills in the last piece of being able to solve this problem. We can take ICE patients when they are early and they've got 1 or 2 clock hours of iris involvement. We can, apparently now we'll be able to see where the edge of the corneal endothelial involvement is, and we will potentially be able to offer these patients surgical removal of the involved ICE tissue when they're in their 20s and solve them 25 to 30 years of agony. And so I think that your techniques are going to have tremendous application for that. I'd love to talk to you afterwards about it.
And so the way really to popularize this is more people have to get this device, and it has to become FDA approved for us to really use it clinically.
Carol, do you want to add something?
Kathy, beautiful talk. I was wondering if you have used this device to look at donor tissue.
No.
Can you adapt it to?
That's a good question. Most donor tissue screening is done in the eye bank. I'm not aware that any eye banks have this device. It is a contact device on the cornea, so I don't know the logistics of how that would work. I mean, most screening is done on the tissue, the donor tissue upside down. But yeah, it's a great idea.
Any other comment? What about
Not for Catherine, I'm waiting online to speak with Dr. Snyder. I'm online here waiting to speak with Dr. Snyder.
Thank you. Yes. What about the publication of Snyder? Please.
Yeah, I really believe that it's fantastic. And you enlightened my mind because I had some patients where after I fixed the iris, I was absolutely worried about the future of this eye, and the transplant is one of the, 3 patients have the best follow-up of the corneal transplant. So finally I found the confirmation that we should fix iris when we do EK. So thank you so much for this. But I want to ask you, how do you decide the diameter of the iris? White to white, that's it, or one little bit more or less?
So, great question. Finding the diameter of the iris, I actually measure the internal anterior chamber. There's a 23 gauge ruler forceps that's available through MST. I think there's some other people who make them as well, that you can measure up to 16 millimeters, and just with the paracentesis, you can place the ruler into the anterior chamber, measure the entire space, and then I usually like to take off about 1.5 millimeters so that there's a little peripheral gap, so there's no internal coverage. As it turns out, in unicameral eyes, with no zonules at all, and the sutured implant, there's often well more than enough space for an untrepanated device. But if the zonules are still present and we want to avoid solely body contact, I'll basically measure directly, take off 1 millimeter.
So the second question, because the line is long, see, it's do you remove always all the iris or just the compromised iris? For example, if you have a big fibrosis in superotemporal part, you remove all the iris or just the part that is interested from the inflammation, fibrosis, etc.?
Well, typically, if there's only a couple clock hours of involvement, then I'll only remove part of the iris. If there's more than 3 or 4 clock hours of involvement, my experience has been that if you don't leave a healthy amount of iris tissue left, then when you place your bubble, it tends to flop forward. And so I lean more and more toward removing more tissue unless it's a very, very focal area that's involved.
And this is the third question, the last one, sorry, I would like to do 150, but I will finish this last one. Do you put some adrenaline into your chamber before you cut the iris, or just try it gut?
Probably would be a good idea. I haven't done that. I've really relied upon infusion pressure if the iris root starts to bleed a little bit. Interestingly, the iris root doesn't usually bleed in most of these cases because the iris has been so badly damaged and it's so atrophic that there's no blood vessels left. But that's a great idea, which I think I will start doing. Thank you.
Yeah, and thank you to you, and I'm very happy that I didn't lose your talk. Thank you.
Well,
Just a brief comment. I'm probably the largest referral source to Dr. Schneider for these kind of cases because, and I want to just highlight something. I think broad peripheral PAS is one of the most unrecognized causes of repeat graft failure. And I think surgeons think they go in and break the synechia and then repeat the DSEC or the PK, but they fail. They fail probably from immunologic and mechanical reasons. And so I get patients sent to me because they think they're high risk, they need immunosuppression. But it's the iris and the broad PS, and the work you've done is really outstanding, and you've helped many of my patients. So thanks, Mike.
Well, thanks to you, Ed, because you've been extremely supportive in this and so much of my work, and I really appreciate it.
Mike, as usual, you're Superman. Amazing procedures. So now that you've done 30-ish, and I was thinking the same thing, that the iris is atrophic and maybe doesn't bleed, but sometimes it does. So do you recommend the peel? Or are you the Pac-Man munching with the retractor? What's the best approach to avoid potential bleeding and cyclodialysis?
So I think that the peeling approach I've now restricted primarily to very atrophic light blue irises because the tissues are usually much less tightly adherent. Brown iris or some healthy tissue, I'll usually go right to the retractor. The other thing that's a nice tool to have available is if we have an anterior infusion and we see that there's one area that's oozing a little bit, 25 gauge microcautery to the oozing spot usually will take care of it pretty quickly.
Thank you so much. Thank you so much. Let's move.
Just a brief comment. We have experience with artificial iris, especially when we combine with PKs. And we have really too much endothelial cell loss over time, especially with scleral fixation iris, artificial iris. So now we try to combine these artificial iris just in the back to have more space maybe with arteries. I don't know if you have as an experience, what do you think about that?
Yeah, so if you can place the device in the bag, it is always, 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 always the best choice. No question about it. If you don't have a capsular bag in which you can place it, well, ciliary sulcus is the next best option. There's a couple things that can reduce the likelihood of graft problems in these patients. One is that we will only modify the device by trephination. Some folks have previously done pseudo-iridectomies, being concerned about angle closure, and as it turns out, we have never used pseudo-iridectomies and it's not a challenge, but any modification that one does to the periphery of the device creates a sharp corner. And we all know that our patients still rub their eyes. I rub my eyes. I know I'm not supposed to, but I do, I'll confess. And we know that if they do this and there's a sharp corner, they're going to develop inflammation against the sharp corner when they cause mechanical impact. And I think that may be one of the reasons why some folks have noticed this. I have not noticed a graft longevity issue in these eyes more than I ordinarily would. But in all fairness, many of these also have 1 or 2 tubes, and grafts just don't last as long in eyes with tubes. Thank you.
Thank you. Let's move on to the first live patient evaluation. Please I invite Dr. Camilla Bianchi to present the first case.
Good morning, everyone. Today I would like to present you this case of desamethyl in a patient with rosacea-associated blepharitis. The patient is a 31 years old woman with no history of trauma or infection, but with diagnosis of rosacea that was referred to our cornea clinic for blepharokeratoconjunctivitis. At the slit lamp examination on June 2024, were revealed blepharitis, conjunctival aperemia, and a corneal ulcer with neovascularization, as you can see on the picture. The best corrected visual acuity was 0.5. And on June 2024, we started therapy with fluorometholone eye drops twice daily, and tear substitutes 4 times daily, and a nocturnal ointment with antibiotics. Then we started a cycle of oral doxycycline. As you can see on the pictures below, in June 2025, the corneal ulcer gets worse and enlarged, and then remained stable for the last year. This is the OCT, and you can see the thinning of the cornea. And in 2024 there was a thickness point of 473 microns, and then now in 2026 you can see the worsening of the corneal thinning with a thickness point of 145 microns. So we would like to ask your opinion for this case. In particular, why do you think this desamethyl developed, and how would you explain such well-defined shape? Then, do you think is enough a simple observation due to the stable curves, or do you think we would modify the medical treatment or intensify it? Or do you she needs surgery? And if yes, which kind of surgery? Thank you.
So now it's up to you, gorgeous slit lamp examiner at Holland.
So we can see the dysmethyl, large dysmethyl. So I want everyone to appreciate first of all, the neovascularization and the severe thinning of the inferior cornea, because at first glance it looks like it's just a central desmetocele, but her entire inferior cornea is very, very thin with NV. Can you see the NV there? Yeah, so it's kind of classic what we see with rosacea blepharokeratoconjunctivitis. It's chronic inflammation of the inferior and mid-central cornea and the long-term progressive thinning that you can see in these eyes. I just want to see if we see the same thing. It's usually bilateral. And she does have some neovascularization and scarring of the other eye, but does not have, there's a little bit of a thinning at the 8 o'clock, 9 o'clock peripheral cornea there. Yeah, so let's go back. So we can see neovascularization of the entire lid margin, meibomian gland openings. I'm going to try to express kind of thick meibum, difficult to express. So the findings are surely consistent with rosacea keratitis. And I see this a lot in younger patients that come in with, even in teenagers with thinning and neovascularization of the inferior cornea, and they get diagnosed as herpetic keratitis. But people don't recognize the chronic inflammation that occurs from rosacea. Does the panel need to see anything else on examination? You can do the OCT, yes?
Ed, while you're doing the OCT, just comment about what we have historically called the desmetocele. I've always wondered over the past several decades why these desmetoceles don't always perf within hours or days. And obviously we're going to discuss management, and all of us have different ways of managing them. But since Professor Dewar described the pre-decimate layer in 2013, I think that most of what we're seeing here is not a desmetocele, but really a duocele. The bursting pressure of Decime's membrane is 30 millimeters of mercury. The bursting pressure of the pre-decimate layer is 500 to 700 millimeters of mercury. So if these were all really desmetoceles, just gentle rubbing of the eye would pop it open, and occasionally that happens. But they don't. This is a great image there, the OCT image. So you can see there is, if you want to call it, some stroma there, right there. So I don't think what's separating the anterior chamber from the surface is only Decime's membrane. And it doesn't bulge out that much. So my gut feeling is that this is the pre-decimate layer in many instances. Just an observation.
I think you're absolutely right. There's a little more tissue. It's not pure decimates, and we did use fluorescein. I bet it's epithelialized. So the risk of spontaneous perforation is probably very, very low. The risk of mild Troutman perforation is high. I think the point to make to the audience is, when you look at that, you focus in on this very thin near-desmetocele in the cornea, but the pathology, the inferior cornea has significant thinning and neovascularization. I think these patients are somewhat neglected in early age because we don't manage, they come in actually often with astigmatism, right? The inferior cornea is thin and misshaped. They may not have a severe red eye. They might not have a lot of symptoms, but they have progressive changes of the cornea. So aggressive management of the MGD in younger patients can prevent the progressive thinning we see with chronic inflammation in these patients.
And what did her facial skin look like? Did she have facial rosacea as well? And the other thing is often I'll see this in the context of like a flectennial that sort of breaks down. And there's just some corneas that are more predisposed towards melting than others. And I think, trying to treat the facial rosacea, as you've been alluding to, or the overall rosacea meibomian gland dysfunction, and the associated complications like with the vascularization and the flectenulosis, with steroids and maybe systemic doxycycline or azithromycin, it's a good idea to try to sort of, they always say prevention is better than treatment. So right now we're left with a duo seal as opposed to treating a more full thickness cornea with a flectenule. So I think aggressive management, where we've been lax in the treatment because it's such a chronic disease, but I think we need to be more proactive in these patients.
Yeah, I think the patients that are diagnosed are the patients that come in with an acute red eye, like a flectenulosis or something like that. But the patients that get missed are her, the low-grade relative. You see how quiet her eye is, but she has significant corneal NV and very, very thin inferior cornea. She has a smaller area in her other eye. I think the management is, doxycycline, topical immunomodulator, cyclosporin, lifitegrast, and then loteprednol, I like because they're going to be on it long term. I think if you can reduce the inflammatory reaction of the lid and the tears on the cornea, you can slow or stop the progression.
Giuseppe, do you want to add something? Because she's almost unchanged, you told me, in the last year.
Yes, the very extraordinary aspect of this case is that she's stable for more than 1 year with this picture. So, as you said, the spontaneous rupture is very rare. So this is a confirmation of this. But the other very particular case, I never seen in my experience nothing like this, because usually we see duocere, decimetoceere, coniatine, but they are focal, very, like a point. This is a circle, a round circle of 2 or 3 millimeters. It seems like that you do a cornea biopsy in this eye. It's very incredible how she experienced a similar perfect round circle in 2 or 3 millimeters in diameter, and it is very stable for more than 1 year. I think that, and just last question, vision is 0.5 with best corrective surgery. So surgery just in case of perforation is the question.
So I just want to make a comment on the key to the diagnosis. If the rest of the cornea was normal and she had this near-death metastasis, I think it would be confusing. Her inferior cornea is 80% thin with neovascularization. It's definitely an correct diagnosis. MGD or ocular rosacea induced. She has findings in her other eye. So I 100% agree with the diagnosis and management of her kind of subclinical inflammation is the only way I would know to try to prevent progression and to try to prevent progression in her other eye, which we can't forget about. And lid hygiene, maybe thermal pulsation therapy, because she does have a very viscous, abnormal meibum at a very young age, and she's going to get meibomian gland dropout and have a very poor tear film. I think you have a comment?
No, I completely agree with you. I work in Ireland, so we see a lot of patients with rosacea, obviously. So we need to address the facial rosacea. So as you nicely put, you have to look at the face first, you have to look at the lids. So we use also the topical ivermectin to control the inflammation on the skin. So this is very important, and then that's how you can control the inflammation in the lids, and then go ahead with either, as you said, the pulsation or any other means for NGD.
Thank you, Enrica. Professor Dragona, do you want to say? Please, microphone.
Not working. I don't know whether I can activate it.
It's working. Yeah. Oh, it's going now.
Okay. Well, to me, it doesn't look as a typical ulcer from BKC, blepharokeratoconjunctivitis. It looks like more a neurotrophic ulcer. Did you measure the sensitivity? Sorry, it's reduced. So because the margin of the lesion and also the central, away from, not just along the lid margin, which is more typical for ulcers with in BKC patients. Perhaps this and also the Giuseppe confirmed, which is reduce the sensitivity. Perhaps this is neurotrophic ulcer.
So I think it's a very good point, but I just want to highlight her inferior cornea from 3 o'clock to 9 o'clock.
Definitely, this is true. This is the day.
Right.
Then we started from a PKC.
Yeah.
But the ulcer is not the typical PKC ulcer.
Agreed. Yeah. But as we know, chronic eyes, and she has definitely a very, very poor tear film with probably a rapid tear breakup time. They get neurotrophic, right?
Yeah.
Chronic ocular surface, these patients, and we don't diagnose it enough. So I think your point is very well taken. We don't think to take sensation in eyes like this, and I'm sure her sensation is way down. Yeah. So I agree. I agree with your point.
Thank you.
Vincenzo?
Going back to the Professor Sarnicola question, when surgery? This afternoon.
So, okay, let's go on. So, no surgery, more aggressive systemic therapy, and more aggressive local therapy. Okay. Let's go on with the talk. Giuseppe, role of endogenous TR cortisol, a potential biomarker and novel therapeutic target in dry eye.
Thanks, Enrica, for the introduction. So let's move to the ocular surface and let's see some new insights that we collected in the last month about TR biomarker. So we know that this is the concept of the transition from homeostasis to parainflammation to inflammation. This is like a path of our patient that at the beginning of the stress of the environment, of the risk factors, they develop parainflammation. It's like a compensation, like a reaction of the tissue that try to increase the production of the tears, blinking rate, and epithelial turnover. But if the stimuli persist over time and exceed also a certain level of severity, parainflammation goes to inflammation with decreased production of tears and also decreased activity of the cells. So we should treat the patient when they are not yet inflamed, and in order to try to have better outcomes of our treatment. But we know that cortisol have a role in the stress response at the cellular level, not only for sure in ocular surface, but in all our organism. And we know that cortisol is essential for survival of the cells. And but if it is dysregulated, it is stimulate inflammation, disease, metabolic disease, and dysfunctions of the cells. There are for sure some papers and some evidence about the regulation of cortisol in levels, that it is a systemic regulation, but is also a local regulation mediated by some receptors. So our question was to try to understand if a patient with dry eye disease had a different level of expression of TR cortisol compared to patient of control. So to data, before our evaluation, data in the literature were controversial. There was a paper on conducted in patients with chronic ocular surface disease, like Stevens-Johnson syndrome or pemphigoid, who showed that this patient had an increased level of cortisol. On the contrary, another paper on dry eye disease showed that this patient had lower level of cortisol in the tears. But in this case, the levels were perceived as a percentage and not as a total amount of concentration. For sure, there is a role of systemic characteristic of the patient. For example, we know that cortisol is a stress biomarker, so patients with anxiety has a higher value of cortisol. So there is also a systemic influence of this marker. So, in order to try to understand more about this, we try to conducted at this point, we defined the physiological level of TR cortisol, we evaluated the level of cortisol in dry eye patients versus control patients, and then we try to understand if installing eye drops with cortisol, we could influence the TR level of cortisol in these patients. So the first step was to validate the method, the technique of mass spectrometry, and we conducted this on healthy volunteers. As soon as we validated the procedure, we started the first study comparing health subjects with the patient with mild to moderate dry eye and patient with severe dry eye. So 3 groups: control group, mild to moderate dry eye, and severe dry eye. For sure, our patients stopped any corticosteroid therapy, both topical and systemically, that could interfere with these levels, and we collected tears at the same time in the morning for all patients. These are the results of the study. You can see that the patient with severe dry eye, in the line at the bottom, you can see the TR cortisol levels. You can see that the severe dry eye had higher value in a significant manner compared to both mild to moderate dry eye disease and compared to healthy subjects. So healthy subjects has a lower level of TR cortisol. Then we had the mild to moderate dry eye that had the intermediate level of TR cortisol, and severe dry eye had the higher levels of TR cortisol. We conducted also correlation of these TR levels with other symptoms and other parameters, including symptoms and symptoms, and we found a good correlation with all these scores. So patients who had worse symptoms had also higher level of TR cortisols. The second point was to try to define how this TR could change in a case of instillation of exogenous cortisol. So in this second phase of the study, we enrolled patients with mild to moderate dry eye disease, and these patients were randomized to receive hyaluronic acid 0.2% plus hydrocortisone 0.001%. This was the treated group, while the control group received just hyaluronic acid 0.2% alone. We for sure repeated all the previous examination, and these are the results. You can see in the left figure the interesting difference between the two lines. The blue line is related to patients that were treated with the hyaluronic acid plus hydrocortisone 0.001%. You can see that how the treatment with this product allowed the reduction of TR cortisol compared to the orange line that are patients treated just with hyaluronic acid, in which the concentration of TR cortisol remained stable over the treatment of 45 days. While if you treat the patient already after 15 days, there is a drop of TR cortisol levels that is maintained over time during all the period of treatment. And we for sure studied also other aspects, so symptoms, ocular discomfort symptom in the left, that you can see in the blue line, they improved in patients treated with hydrocortisone at a low concentration. And you can see also in the opposite how in the right figure tear breakup time increased after treatment. Of course, we studied again other correlation, and we found an interesting correlation of TR cortisol level with increasing mood. So patients with a decrease in cortisol levels after treatment had also an increase of TR breakup time, and these two trends correlated well between. So these results that open a new insight in this cortisol level and in the role of TR cortisol are very interesting, and maybe support the good feeling, the good evidence that we collected in the last years with this product. These are different papers and different studies that show the positive outcomes for both sickness and symptoms after the use of hyaluronic acid plus hydrocortisone at low dose. This is the registration study that showed that the association of fluorometron plus hyaluronic acid and hydrocortisone worked better than fluorometron plus hyaluronic acid alone. And this works also for staining, breakup time, and reduction of inflammatory markers. This is another multi-center collection data that we conducted in Italy with Rita, Professor Aragona, and other Italian experts, in which we compared this product with other normal conventional TR substitute, and we demonstrated that the addition of low-dose hydrocortisone in the TR substitutes allowed a better result in tear breakup time compared to the conventional ocular surface ocular lubricants. For sure, intraocular pressure is a potential issue, but in a previous study, as in our study, no problem, no issues with intraocular pressure was shown during all the study. And again, as before the conclusion, I show again this path. That is the path of our patient who experience later dry eye disease and chronicization of inflammation. If we start treating this patient in this intermediate phase of parainflammation, we could recover potentially the homeostasis, avoiding chronic inflammation. So we know that TR cortisol levels are different in dry eye patients, are higher in dry eye patients, and we know that integrate hyaluronic acid plus hydrocortisone at low dosage can reduce these TR levels that go towards normality range. For sure, further studies are needed to understand how this can be maintained over time and how this can guarantee a better prognosis for our patients with dry eye. Thank you so much.
And now, after all, one words blurred picture. Stop saying dry eye when you mean pain.
Okay, so thank you so much for inviting me. It's one of our favorite meetings, and thank you for staying till the very end. So I'm going to switch gears a little bit and talk about the other aspect of dry eye. I do consult for companies that care about dry eye and eye pain. And so this is my view of the world of dry eye. Many people feel their eyes in an unpleasant way, and oftentimes they use the word dry, but not always. And my goal, the goal of many people here, is to figure out what is causing these sensations. But the problem is, the current state is no matter what we see, a patient usually leaves the office with a diagnosis of dry eye, even though these patients look very different. And I think that's not the best way to think about things, because first of all, your eyes can feel dry and not be dry. Most of your cases, the last case presentation, Schirmer's were normal in these patients with high OSD. So I don't like using the word dry eye unless I mean it, or it's important to think about dry eye more as an umbrella and not one yes or no condition. But the way I like to think about the world is if you hear the word dry or any other pain descriptor, just use the word pain or discomfort, because that means nerves are firing, and then we can just figure out why they are firing. And for me, a useful way to split up the world is to nociceptive causes of pain. It means anything at the level of the ocular surface or environment that is triggering pain. And so this is not dry eye. This is an ectropion. Thankfully, I have Andrea here. She can fix that. Okay, but the other hat is the nerves themselves may be abnormal. That's what we call neuropathic or nociplastic. And that can occur at the level of the periphery or center. So the first thing to think about is when a patient tells you their eyes feel dry, that sensation of dryness is coming from the brain. And so everything, all sensations, they may start peripherally, but then there are nerves that process those sensations. As anything you feel anywhere comes from the brain. So the punchline is we can't ignore nerves and we can't ignore the brain when someone tells us they feel dry or anything else. And so what we're going to talk about today is why we need to really rethink how we use the term dry eye so that we can better serve our patients. Okay, so dry eye is not one thing. It has different symptom sign combinations, and the punchline is they're driven by different things that need to be targeted differently. So to me, we just need a bigger, as we get more and more data, we need a better framework to think about this. And I think the best way to do this is to illustrate it with a case. So this is one of my patients. He's diagnosed with dry eye since he was young, but we're not going to stop there because we know dry eye is just the beginning. So his symptoms worsened after LASIK, then in his right eye further worsened after his retinal detachment repair. And I want to understand, what is he complaining of? Burning, dryness, radiating pain. Okay, so I also want to know who he is. He does have headaches and a history of migraine. He has this weird periocular dermatitis that no one can figure out how to get rid of. And the good thing is, by the time patients come to me, they've seen lots of other people. So I know what's worked and what hasn't worked. It has not worked to treat his inflammation, but treating his eyelid findings has helped a bit. And when he saw me, he was on these medications and was not doing well enough. And so I do think that these composite scores are helpful, but ultimately I like to keep things simple. I say, whatever it is that you feel that you think is painful, just rate it. And you can see he has pain in both eyes, right more so than left. And then my exam starts when I walk into the room. I was so happy we heard about rosacea. I think we all need to be periocular dermatologists, and he does have rosacea. Then I look for inflammation, and I can't detect it on his ocular surface, but sometimes I do find inflammation, and the more pink the stripe is, the more I get excited. Then I start with all of my meibomian gland tests. Looks pretty good from anterior blepharitis, but he does have various signs of meibomian gland dysfunction, including severe dropout in the right eye. But his bulbar conjunctiva looks pretty good, other than changes from his scleral buckle, and he has no papilla or follicles. His LASIK scars look great, but my secret weapon are my combined fluorescein and lissamine strip. I go in all at once. And what I can see is his tear stability isn't great. He has some staining, but he does not have aqueous tear deficiency. So does he have evaporative dry eye? Well, I don't love that term because we actually are not measuring evaporation. That means thinning of the mucoaqueous layer. He does have MGD with gland atrophy. So what about short T-butt dry eye? I don't love that either because it assumes that short T-butt is what's driving the symptoms. And it may be, or it may not be. I think we need to be agnostic to the source of symptoms. So another one, is he in a vicious cycle? I hear that all the time. I don't know, he may be, but we have to be honest with ourselves. We don't know the natural history of dry eye. It's not clear that everyone has the same natural history. And from the studies we do have, it doesn't seem like the things that we call signs of dry eye are changing over time. So I think we need to just acknowledge what we know and what we don't know and keep an open mind. The one thing I always check is there something in his body that's showing up in his eyes? I test a lot of patients for autoimmune diseases, and I couldn't find anything with him. So then I look for hidden inflammation, because of course we know that inflammation is often a driver of symptoms, and that's where I use my confocal. You can see here in panel A, there is a ton of hidden inflammation in an eye that is totally white and white. You wouldn't have been able to see it otherwise, where in B, there was no hidden inflammation. And so these are his confocals. You can see his right eye doesn't look the same as his left eye, but not a ton of inflammation. Plan A is always treat what you see. And I think there is inflammation because he can't get lower than twice a day of FML, and I can't figure out how to treat his periocular dermatitis. So I went for the one anti-inflammatory that he hasn't tried, cyclosporin 0.1%, and that is because we know that not all anti-inflammatories are equal. Some patients prefer cyclosporin, some prefer lifitegrast, some can't tolerate either, and we couldn't figure out which factors predicted response. But the good news is he could tolerate the cyclosporin, but his pain was the same. And of course, what we're missing, of course, is that nerves are driving pain, and his nerves are probably unhappy. So how do we check that? We start with a symptom check. We're looking for neuropathic nociplastic descriptors, and he has them: burning, sharp, shooting. You have to test corneal function in everyone, and I look for abnormal or normal. And then I like to try to localize the nerve abnormality with my anesthetic challenge. If the pain mostly goes away, it's likely ocular surface, and if it doesn't, then it's probably not ocular surface. And I also check for cutaneous allodynia. So in his case, he had markedly reduced corneal sensation. His pain got better, but not completely gone with anesthesia, and no cutaneous allodynia. So it turns out his nerves are not normal. And so what I have is this little checklist, if anyone wants it in Word document, and pretty much the more checks you have, the more likely there's a nerve abnormality. He has pain in the appropriate context, he has comorbid pain conditions, abnormal sensation, persistent pain with anesthesia. We've treated what we see and it's not getting better. This is probably a nerve problem. So plan B is treat the nerves, and the question is how to do it. And the first thing is be honest, tell the patient there are no magic fixes, things go slowly, and the goal is good enough. But there's a whole field of neuromodulation, and oftentimes we need to do multimodal therapy, but no matter what we do, neuromodulation takes time, and patients need to buy in. But never tell a patient there is nothing more we can do, because there is a whole tree of neuromodulation, so many things to target. Now, he didn't want to be on oral neuromodulators, but he has a history of migraine, so I can treat him with things that are used in chronic migraine. I love TENS units, I love botulinum toxin, who doesn't, and tinted lenses. And we have done many studies looking at these therapies and their effect on brain activation, showing that they reduce activation in areas that process pain. The other thing to remember is that patients with eye pain have an emotional response, and we think it's because the eye is wired to parts of the brain that process emotions more so than the back and the knee. So what did we do? Well, he was already using scleral lenses, and we felt like we were treating his inflammation, so we added some botulinum toxin and a TENS unit that's approved for chronic migraine, and we talked to him about positive coping mechanisms, and he was better. But the clincher is he identified he was allergic to the hand wash he used at the hospital. He was a GI physician, is a GI physician, and his periocular dermatitis went away, and he was even better. Okay, so we absolutely took a few months, but reached our goal of good enough. So how do I think we need to think about eye sensations? Use the word dry eye cautiously. Aqueous tear deficiency, or as an umbrella term. And think about these other dry eye terms that we throw out that may not reflect our reality. I think the way to think about it, if a patient has pain, call it discomfort if you don't like the word pain, think that nerves are firing, figure out why they're firing, and target them. Thank you so much.
Thank you. And this from
Tear dysfunction syndrome. That's a much better job.
For bringing that up. You know, we think this is something I feel very strongly about. You know, we call it a dry eye,
And the treatment for a dry eye is to wet it. This doesn't work. You know, these are patients who come in with neuropathic pain, and I have a few of them who want to go through medically assisted suicide. It's that bad. And I think just treating it with dry eye makes the patient very frustrated, and it also makes the doctor very frustrated. I've had some good results with PRP, with topical steroids, but nothing works unequivocally, and I think you have to think out of the box. Things like gabapentin or Lyrica. I've been a little bit underwhelmed, but I've had some success with that, so I think you've got to try different treatments. But calling it a dry eye or pain without stain is a disservice to the patients. It's not going to treat them with artificial tears. They need significantly more, and I'm really glad that you brought that up. Just one more comment, if I could make, about the other one, the other talk. I love the idea of acting sort of proactively with dry eye. You know, if you look at our cardiovascular colleagues, they're not going to tell a patient to stop smoking after their first heart attack. You know, you want to get them treating, you know, their diet, their exercise, stop smoking well before. And I know dry eye patients will get worse. So when we see young patients coming in with dry eye, and we know that the natural sequence is they're going to get worse over time. So I think we should be a little bit more aggressive with their treatment and not just say, well, we'll treat you when you have dry eye or when all of your meibomian glands have dropped out. You know, you want to get there before that happens so that you're working with some functional tissue. So thank you for bringing that up about the pain.
Thank you. Karen, do you want to add something?
Yeah, two things. First, for those of us in the U.S., is the low-dose hydrocortisone commercially available or it's compounded?
Yes, this is commercially available in Italy, and we use it like an enriched tear substitute when we want to, for sure, using the effect of, well, non-effect of hyaluronic acid, but we work also more on inflammation or parainflammation of patients.
Beautiful work. And I had another comment, Dr. you've really been such a pioneer in this, but one of the things I find so interesting, which you mentioned, and also your functional MRI work, is that ocular pain is connected with emotion. So we see these patients and we're thinking, oh my God, they're crazy. But you've shown that really there is this connection between emotion and the discomfort that people are feeling in the eye. So, thank you.
I just want to make one comment to Alan. Like, I totally agree with you that we should figure out when to intervene ahead of time. But I think we need to acknowledge that not everyone is going to get uniformly worse. And we don't have good natural history data on meibomian gland dropout. And so we just don't know. And so I think what we need to do is define the natural history of the different subtypes so we can figure out when we should intervene and when we don't need to. And so again, to me, the whole point is it's not one size fits all. It's never a yes, no, both with the diagnosis and probably with the course. And what we need is to think about it that way so we can try to parse it out and have better details that then we can then help our patients.
Just a quick question. Great talks, both Anna and Giuseppe. I would completely agree with you. I also do a lot of investigation because I do believe that the dry eye is not the dry eye, so I feel that there is a lot of autoimmune connection behind everything before the pain. And just for Giuseppe, have you maybe considered, I've seen you did the tear breakup time test. Have you maybe considered to do the tear meniscus height as well, maybe for further studies?
Yes, we measured the shimmer test, not the tear meniscus height, but shimmer test, also because to collect tears, we should investigate patients with enough tear to be collected for the analysis. So we included the patient with at least 5 millimeter of shimmer tests that were needed to harvesting the tears. And so usually this patient had normal or reduction tear production, but not extreme dryness, because at least 5 millimeter of shimmer were required.
Thank you.
Thank you. Let's go on, please, with the second live patient evaluation. Please, Dr. Michela Iba, on stage just to present the case.
Okay, good morning. Hello, everyone. I will present a particular case about a woman. She is 64 years old. She has a long-lasting history of photophobia and dry eye, dating back to early childhood. She was referred to our clinic for endothelial keratoplasty in left eye, and she had a diagnosis of punctate keratitis. At the slit lamp examination, she had diffuse punctate keratopathy, corneal stromal opacity, central corneal edema, and that was more evident in the left eye than the right one, and nuclear cataract. The best corrected visual acuity in the right eye was 0.3, and in the left one was 0.6. She started before our meeting a therapy with tear substitute, and after our meeting she started a therapy with tear substitute vitamin A ophthalmic ointment. We suspected a vitamin deficiency, and so we asked her to do some serum examination. The dosage of serum levels of vitamin A were within the normal range, but she said us that she had a recent diagnosis of Helicobacter pylori infection. In the right eye, we can appreciate in this image the stromal opacity, so this edema that involves the visual axis, and the punctate keratopathy. The cell count, the endothelial cell count, wasn't possible to be detected in the central sector, but it was detectable in the superior sector, where we can appreciate a reduced cell population. Then in the left eye we can appreciate a similar condition, so the stromal opacity, the punctate keratopathy, but in this case wasn't possible to measure in any sector the cell count. We recorded this video with the micro rack to show you how is evident the stromal opacity, so the corneal opacity that involves the visual axis, and that's why the patient probably couldn't have an optimal visual condition. Of course, in the right eye and also in the left one. So we are really curious to know your opinion about the diagnosis of this patient, and how would you manage this patient? So should you continue the medical therapy, or should you prefer like the endothelial keratoplasty in the left eye, or what are your ideas about it? Thank you.
So we have a request for the panel to discuss your ocular findings, but after the patient leaves, we'll discuss diagnosis and treatment. So we'll just restrict it to the ocular findings right now. Right at here. So can you see the central stromal haze? That's yeah, right there. And this was the eye with the low cell count, is that right? Yeah. Well, the right eye has, see the haze in the right? Yeah. It's actually bilateral. The stromal haze is bilateral. And there's some pigment clumping on the endothelium. Do you see the pigment there?
Yes.
So it's an asymmetric but definitely bilateral condition. With this one has stromal edema and a little epithelial edema. Let's go back to the other eye, the endothelium. What was this? Would you get a cell count in the right eye?
In the right eye, was dust in the periphery.
Not centrally, right. So it's bilateral corneal edema with stromal haze, but asymmetric. Any other requests from the panel before we let the patient go?
Can we ask her again about her major complaint and the duration of her complaint and whether it's getting worse? Because I thought I heard that she's had a problem since childhood. Why do you think?
I visited the first time 2 months ago. I do not know very well the patient.
Yeah,
Any family history of similar problems? Family history of similar problems.
Can you see the limbal deficiency?
Yes, very well.
And then it goes on kind of central punctate, so far peripheral limbal stem cell dropout with a mosaic pattern and a little area inferior nasal. You can see that area of microcystic edema centrally.
Yeah, it's a staining. Staining. You can see those are conjunctival epithelium coming down.
Very minimal limbal cell dropout superiorly.
And there's the other eye. It's a little different, with some focal areas. Yeah, but that's...
So it's kind of interesting. She has more ocular surface changes this side with less stromal haze and edema, and the left eye has less ocular surface findings with a much more prominent stromal haze and edema. Any other requests?
I have the same question as Dr. Karp in terms of family history. I also had a question, was she ever a contact lens wearer? And the third question is did she ever use drops that were not prescription drops, maybe vitamin drops, homeopathic, something else that she was putting in her eye?
No history. Never used the contact lens, and no relatives with ocular issues.
Can you ask her, did she ever use any other things in her eye, homeopathic?
Qualcosa di particolare.
What about her superior palpebral conjunctiva? Any problems there? Did you flip the lid?
Yeah.
That's exactly what I was about to say.
Actually, if you look carefully, the stromal edema is central, but it's also superior. So if I lift her lid, you see the mid-periphery here? She has edema and haze. Her edema and haze is central, and it goes all superior. I don't know if you can see that or not. Palpebral kinds looks fine. Any other requests?
Sensation.
No.
Is the sensation decreased?
Sensation decrease. For the youngest, did you see how well we can see the limbal cell deficiency using simply fluorescing? Very, very good imaging, really. So, it's a different point of view. Have you some considerations?
I'll let the panel take this one first. I mean, let's put together a limbal stem cell deficiency in the right eye, which affects the superior third of the cornea, central edema and haze without glucana, left eye, central and superior corneal edema with a localized area of pigmented accumulation without cuttata, with very minimal limbal deficiency. Should be easy for you guys to put this all together. I don't know why you're not. I mean,
when I saw the patient for the first time, I see the eye and say, okay, she has a vitamin A deficit. Because she's very, I go, okay, I do the test normal. So the question was, do you do endothelial keratosis in the left eye?
Anna, no. Can you perform OCD?
Yeah, there is the CT image in the...
No, I didn't see now. No, so we can do it now with MS-39.
No, sure.
Pasquale?
Well, in some spots, I saw images that resemble very much epithelial membrane dystrophy. Perhaps it's two different things occurring in these patients. One problem in the epithelium and one problem in the endothelium. Not this one, but in the other eye. Oh, here there are some. If you see the dark spot, which is staying with the fluorescein, that one resembles a basement membrane. In this one are definitely resembling those conditions. So I think we should start thinking two different, and again, what is the corneal sensitivity of these patients? Because if it's reduced, then you can see also to nerve problem. If not, it's just an epithelial or perhaps something, say, genetic or a variant anyway of familial condition.
What theoretical suggestion? In my opinion, no surgery at this point. Yes. No, please.
This is a dry eye since many years. I mean, ocular complaints since childhood. For the pocket.
She
50 years.
And she never wore contacts, right? She never. I mean, her right eye looks classic, like a moderate limbal stem cell deficiency from contact lens. That's the right eye does. But I don't know how you put limbal deficiency together with bilateral, endothelial dysfunction. Where's Jane? Jane, please give us the answer.
Jane, point of view.
So I can't put the limbal stem cell deficiency together with the endothelial abnormality, but I can tell you there was an older entity that no one talks about anymore, and some of us may remember, non-glutate endothelial dystrophy. And what that was is it was a decompensation of the cornea with time, and you didn't see the glutate. But in the IC3D, we do have some pathologic photos that when you took off the corneas with PAS staining, these were buried glutate in decimase, so you couldn't see them clinically, but you do see them pathologically. So the patient, that could explain why you don't see glutate here, and her endothelium is decompensating. I sort of, as you said, he's very suspicious as why do you get limbal stem cell insufficiency out of nowhere. You didn't see shortened fornices or anything like that. You didn't, So it seems like, what did something get in the eyeball? That's what I would wonder. But I don't know of anything which puts together decompensating endothelium without a toxic injury, just naturally forming disease, endothelial abnormality with a limbal stem cell. I'm not.
There actually had a case here 2 years ago. It was hipoclens in the eye from a plastics procedure, but she denies anything. Because her pattern of edema is centrally in the right eye, but it's central and superior in her left eye. It's not the classic, hereditary, you think would be central and symmetric. And we know hemoclans is toxic to the epithelium as well as the endothelium, but she denies any exposure to any chemicals. But
so I've seen hemoclans. It would make sense that they could get limbal stem cell insufficiency from that, but the ones I've seen didn't have limbal stem cell. They just had the edema,
right.
But they didn't have the stem cell insufficiency.
I agree. I mean, it's endothelial compensation. That was reported in the AJO years ago.
Yep.
And I think we see epithelial toxicity, but I've not seen limbal deficiency from that either. So I don't know how you put the two together.
So I would still want to go back and sit down with this patient, go over every little thing, because when people take vitamins by mouth, they don't tell the doctor because it's a nothing. Or you did this once, it's a nothing. It just seems strange. It just seems strange, and obviously it is, otherwise he wouldn't be presenting it here. But could there have been something else that got in that? Was she using well water on something? I mean, something you wouldn't think about as the individual because it was just so natural, but maybe that's the answer, at least a part of this, not necessary to the endothelium.
Giuseppe, is she more symptomatic in that right eye from discomfort point of view? We know the left eye's worse. Both likewise. And has the right eye been treated with serum tears or PTRF or a scleral lens? Those are things you could
OCT, because they have that.
The other weird thing about it, it was a topical toxic exposure. It would be worse inferiorly than superiorly. If something hits the eye, we see chemical explosions. They're always worse inferiorly than superiorly because of the Bell's phenomenon. So another conundrum here.
The issue is the chronicity of this problem, right? I mean, she complained to her surgeon, whom she met 2 months ago, that she's had difficulty since childhood. When you talk to the pediatric geneticists, they sometimes, when they don't know the answer, they refer to these patients as syndromic. They have some kind of a syndrome, or a vitamin deficiency, or malabsorption syndrome. There's something that can tie it in, but it's not acute. She's had it for a long, long time, and we're struggling to figure it out based on what we know. I think you will figure it out, but not today.
So, genetic consulting and no surgery for now, and follow the case. And to be interesting if next year you can tell us how story going on. Huh? Okay, let's move on. So, corneal neutralization, indication and technique, both left.
Hello everybody, and I want to switch gears a little bit here. I want to thank the Sarnicola family for inviting me. I was first, my slides are not up. Slides please. I was first invited to this conference in 2023 to talk about corneal neurotization, and I'm so happy to see that there are 4 talks on corneal neurotization this year. So I'm happy that the technique is gaining some traction internationally. I hope to see many, many more talks about corneal neurotization in the years to come. So also my financial disclosures, I just have to disclose that I'm an oculoplastic surgeon and I'm going to talk about surgery. So that's my major financial disclosure. So corneal neurotization is an effective procedure to restore sensory innervation to a neurotrophic cornea. It's the surgical transfer of healthy sensory donor nerves to an insensate cornea. And so I'm going to talk about indications. This group knows more than any oculoplastic surgery that there are many causes of neurotrophic keratopathy. But I like to think of them as causes that happen distal to the trigeminal ganglia, which is in Meckel's cave, and so it's impacting the peripheral nervous system, versus those causes that are impacting the nerve proximal to the ganglion, which means that it's in the central nervous system. And so who's a candidate for this? Corneal neurotization has been successfully performed in all Mackey stages of neurotrophic keratopathy. So I don't think it's necessarily the severity that matters, but really the location and the etiology of the disease, the progression of the symptoms, and the corneal sensation. So again, if the injury happened proximal to the ganglion or it's congenital, so it's within the central nervous system, then I don't think that those nerves are going to grow back. I do think that neurotization should be considered. But if the injury is distal to the ganglion or if it's on the ocular surface, then I do think that there's a very good chance that there could be improvement or regeneration of those nerves. And so certainly non-surgical treatment should be considered. And if they progress, then you can consider neurotization.
and also checking the sensation. There are certain patients that we would not do neurotization on, and so if there's ongoing inflammation or infection, if they don't have a healthy sensory donor nerve, if they're having radiation to their ocular surface, those patients are not going to be good candidates for surgery. We then need to check the corneal sensation, so we use this Koshebane aesthesiometer, 6 centimeter nylon filament. If it's long and they can sense it, they can sense well, and if it's short and stubby and they can't sense it, they can't sense well. We can also use a cotton swab, nerve conduction tests for kids, but usually when kids have congenital injuries, they have this telltale sign of an ulcer, a facial ulcer, usually around the nostril from picking their nose, but you can also do nerve conduction studies. Normal sensation is 60 millimeters or more, but if they have sensation of maybe moderate or low sensitivity, so 40 millimeters or less, then you could consider neurotization for those patients. There are two main camps of techniques, the direct and the indirect techniques. So let's talk about direct. Now for any neurotization procedure, you must have an intact sensory donor nerve. Luckily, we have many options to choose from our trigeminal nerve. So we have the supraorbital and the supratrochlear, the infraorbital and the mental nerve, and then we also have the greater auricular nerve, which is actually from the cervical plexus that is located behind the ear. We can do unilateral, contralateral, or bilateral neurotization. So we have a lot of options to choose from, and so then we think about things like the size of the nerve and the axon number. The axons matter. You need at least 900 myelinated axons to get to your cornea for an effective neurotization. The proximity of the nerve, closer is better. And then things like donor site morbidity, the accessibility of that nerve, surgeon preference, etc. So the direct neurotization was first described by Terzis in 2009, and she's a plastic surgeon. And it was this bicoronal ear-to-ear incision where she directly dissected out the supraorbital and the supratrochlear nerves and then took them through an eyelid crease incision and then brought them onto the fornix and then subtenous dissection to the corneal-scleral limbus. And I'm seeing all of you wince in the audience. And I can understand why ophthalmologists did not think that this was a good idea. But then in 2020, Elio Lengold and his team, he first published the minimally invasive direct neurotization technique. And this is a video. So it's just an eyelid crease incision. Any oculoplastic surgeon can perform that. You dissect up to the orbital rim. You find the supraorbital or the supratrochlear nerves 2.7 or 1.7 millimeters away from midline, and you dissect out that nerve, kind of like a superficial temporal artery biopsy. You just dissect out that nerve. You need 5 centimeters, and then you just dissect the fascicles. You create a blepharotomy in the medial eyelid so that you can take your direct nerve and bring it onto the fornix. Subtenous dissection to the conj and the limbus, and then you dissect and put your little fascicles to the corneal-scleral limbus. And here we're using some to seal, but you can use scleral tunnels, you can use sutures, etc., and then you just close your conjunctiva. So that was the direct approach. But now there's indirect approaches that are more minimally invasive. And so in order to do an indirect nerve neurotization, you need 2 more steps. You still need to have an intact donor nerve, but now you also need to have an interpositional nerve graft. Luckily, the body gives us multiple options as well. You can take the sural nerve from behind the leg, or you can take the greater auricular nerve from behind the ear. These are nice because they are very long, which is good for bilateral or contralateral cases. They have Schwann cells to help with regeneration and growth factors. And then we also have allografts. Allografts are cryopreserved, decellularized cadaveric nerve grafts. And so these are nice because you don't have to have the expertise of taking a nerve from another part of the body. You don't have to have second site morbidity, surgery time, etc. But they're costly, they're not available in every country, and they're only 7 centimeters. And that's not really long enough for a contralateral or bilateral case. And they also lack Schwann cells, and jury's still out if that really matters for this length of neurotization. Step number 3, you have to understand coaptation. That's the connection of your nerves. So now you got to connect your donor nerve to your interpositional nerve graft. And so we do that by connecting our nerves end to end. So when we cut that donor nerve on its end, it's going to undergo regeneration. Or end to side. When we cut that donor nerve on its side, it's going to undergo regeneration, and then those nerves are going to go through the graft. We also have different adjuncts that we can use to help the union of that coaptation. Amniotic membrane, nerve connectors, nerve wraps. So now let's talk about indirect neurotization. So this was first popularized by Baines and the group in Toronto. And so they presented using a sensory donor nerve. Here we have the supraorbital nerve from the contralateral eye, cutting it on its end, and then attaching a nerve graft end to end and then the regenerating nerves would grow down the nerve graft to the corneal scleral limbus. What's nice about indirect neurotization is you can use the supraorbital, the supratrochlear, the infraorbital, really any nerve can be your sensory donor nerve. And you have multiple nerve graft options, and so now we have a lot of options, and we can neurotize most patients. So let's go through that video. So here's a patient of mine. We have a blepharoplasty incision dissecting the supraorbital nerve. You can see how large that is, hooking it with a suture. Then we take what's called a right needle to create the blepharotomy, and so I'm just connecting into the surgical space, bringing my nerve graft onto the fornix and then tunneling it to the fornix in a subtenon's plane. Then I'm going to separate my nerve into its fascicles. I typically use 2 to 3 fascicles now, and I take them to my respective quadrants, which is typically going to be 3 and 9 o'clock, sometimes 12 o'clock. I used to suture it with a 10-0 nylon. Now I just use to seal, and then I close my conjunctiva. Then the coaptation part. This is where we're going to connect our nerve segments. So here we're using the nerve graft, and we're suturing it within this nerve connector. Then I'm going to cut my donor nerve, that's me cutting the supraorbital nerve, and I'm going to suture it to the nerve connector, and then use to seal to secure that union 1 millimeter or less between the nerves. You don't want to crush the nerves. You could also just simply suture your nerves together. So this is one of my colleagues, Greg Warshall. He's doing a bilateral neurotization. You can see 2 nerve grafts to 1 donor nerve, and just simply taking a 10-0 nylon suture, suturing the nerve grafts, and then he just uses to seal. This is what the patient will look like at the end of the case. It's a blepharoplasty incision and then a peritomy, and patients can do quite well. The procedure can take about 1 hour to 2 hours, depending on your technique. Something important to know is that neurotization takes time. It's going to take 2 to 4 weeks before anything happens at the coaptation site. Then 1 millimeter per day for the nerve to grow. So now the distance of your donor nerve matters. You're not going to really see any neurotization at the limbus for about 2 to 3 months. Then the nerves have to go through the stroma, go up to the subbasal plexus. It can take 6 to 24 months for complete neurotization to take place, so you have to be patient. Now there have been studies that have done comparing all of our different techniques, and this one is from Fogagnola, who I believe is at this conference, and he took a look at indirect versus direct and found there was no significant difference in that technique. We then took a look at 70 eyes that had a variety of different techniques. We found significant improvements in vision, significant improvements in corneal sensation, improvements in wound healing, but no significant difference in approach, the donor nerve location, the graft type, etc. The only thing we found is that kids always do better. There have been many studies now, and going up to 10 years now, even though this shows 5 years, of evidence of anatomic nerve regeneration on confocal microscopy, and so we see that there is durable duration of these nerves in the confocal microscopy. So in conclusion, corneal neurotization is safe and effective. It can restore sensation to the cornea, improve wound healing, improve vision. It's effective for all stages of neurotrophic keratopathy, but you want to consider the reason, the location of their injury, the progression of their symptoms, and their corneal sensation. There are many minimally invasive techniques available, and there is long-term anatomic evidence of nerve regeneration and clinical efficacy. Thank you so much.
Thank you. And now, why are we not doing more dark? Good question.
All right, I wanted to comment on Dr. Costa's amazing presentation because we just started doing neurotization at Wilside Hospital. We've had 2 of them. And thank you for sharing. Thank you for leading this movement. And just a few comments. Everybody in the audience is saying, this is crazy, I'm not going to do it. The truth is, the patients who benefit here have had everything tried before and failed. And I think maybe that's something to share with the cornea specialist. So they've had lubricants, punctal occlusion, synergimin, insulin, amnion, tarsorphy, and they never were able to heal their neurotrophic lesions. So our patient, the one I was involved in, had herpes zoster and had a, not a hypoesthetic cornea, but basically an anesthetic cornea. And the one thing that we made sure to do, and you covered it very quickly, that we made sure that they had sensation in their forehead, the side of their face, so that when we harvested the supraorbital nerve, we knew that it was, I think they used the word competent, I'm not sure, before the oculoplastic surgeon delivered it to the ocular surface. I was fascinated by how much fascicles how much tissue he gave us to work with, because, and then again, any cornea specialist can distribute it around the limbus. And then you went over this in 3 seconds. It was fascinating that confocal microscopy shows repopulation of the subepithelial nerve plexus, whereby you could not identify it before, and now it looked pretty normal. So this is something very exciting. All right, 2 weeks ago, you can bring up my slides. Dr. Sarnicola, Enrica Sarnicola, calls me up and says, I need to ask you for a favor. I said, sure, anything. She says, are you going to be in Cagliari? So last name is Hannush, H-A-N-N-U-S-H, and it's the last talk of the meeting. I'm sure everybody's holding their breath. So she asked me, will you be in Cagliari on Saturday? I said, of course I'll be in Cagliari on Saturday. She says, can you give one more talk? I said, of course, I could never say no to you. And what do you want me to talk about? She says, I don't understand why people in the US are not doing DELC while here in Europe. It's a very popular procedure. So I said, I've already checked with the IT people. They have it, so are you good? Okay, I'll keep talking. I'm good at that. So the question about the United States, and this will save me time during the talk, is it's true, we're not doing as much DLK as in Europe, and there are many reasons for that. Number one, you may say it's an arguably more difficult procedure. Number two, we seem to do so well with the main indication for a simple DALC, a keratoconus, and we've been able to treat all these patients with scleral lenses. And the number of indications for DALC in the US from when we started in 2005 to now has decreased significantly. Number three is that the reports to the eye bank are incorrect. So when I show you the graph in a few minutes, you'll notice that how much DMEC we do, how much PK we do, and then there's a flat line on DELC. Well, I don't think this is reported correctly because surgeons are not reporting correctly what they're doing. They will usually order 2 corneas, one with moderate cell count, one with a good cell count, where they will try a DELC. When it fails, they will use the other tissue, and then they will not report this as an attempted DELC to the eye bank. So the eye bank now, out of about 51,000 corneal transplants we do in the United States, the EBAA, and you'll see the statistics that were just published in April of this year. These are the 2025 statistics. We do about 1/3 full thickness transplants, 2/3 endothelial transplants, and only about 500 DALKs per year. At least that's what's reported. But I think there are more of those being done, or they're attempted and failed and not reported. So just something to keep in mind. And then there's the time involved in doing a DALK, and most operating room administrators will not be happy with a surgeon who is spending a long time doing one procedure. This is spreading around the country, especially at the major university institutions. They're evaluating the surgeon in his or her productivity as dollars per surgeon per minute. Okay, remember this, dollars per surgeon per minute. Okay, Dr. Colby knows all about that as a chair, and she's telling me to move on. There we go. It's my only disclosure. COA makes a urokinase inhibitor. So, as opposed to full thickness transplants for all indications of corneal abnormalities, we now do layer-specific transplants, and as you all know, you've heard so much about it over the last 96 hours. With DELC, we're replacing the anterior 96% of the cornea, and with EK, we're replacing the 4% of the cornea. DELC is not a procedure for limbal stem cell deficiency. Just keep that in mind. You can combine it with other procedures, but in itself, it is not. Okay, you all know the indications, ectasias, stromal dystrophies. The reason there's a question mark next to macular because with macular dystrophy, you know there's an endotheliopathy, there's a glutate endotheliopathy, and you still can do DELC, and they may do very well, and then you can possibly do an endothelial graft later. Okay, we know the advantages of DELC, and if DELC has all these advantages, why aren't we doing more of it? The one advantage that people don't talk about very much is the fact that you're working through a closed system. I know Dr. Holland makes a big point of this when we give our, there's no open eye time, so it's a safer procedure. There's no reason not to attempt this procedure if the endothelium is healthy and viable. All of us who practice in the penetrating keratoplasty years, we always have one or two going in the middle of the night when the patient calls and says, I rubbed my eye, or I fell out of bed, and suddenly I lost all my vision, and they came with a dangling PK and an IOL on their cheek. So that does not happen with DLT because of the bursting pressure of the predecessor layer. All right, so this is the graph I'm talking about, and everyone shows this graph. This is the latest one from EVA from April. So the red line is endothelial grafts in the United States, about 35,000 in 2025. The blue line is the decreasing number of full thickness grafts. And you may say, well, where's DELC? Well, the green line on the bottom is supposed to describe DELC. It's almost like a flat line with 500 cases per year, but the reasons are the ones I've shared with you, okay? The right column shows you the total numbers. We do roughly half the numbers of corneal transplants on the planet in the US, and but very few DELC. Now, the Australian registry has compared PK to DELC, and these are the questions that are always being asked. The best spectral visual acuity is very similar between the two. Refractive error at endpoint is very similar. Graft survival is not similar. A successful DELC will last the patient a lifetime. At PK may not be the case, and I'll show you some endothelial pictures. You know, the only thing to say about intraoperative complications, really, it's a safer procedure, and I think most surgeons will agree with that. And of course, there's less rejection. So this is the same patient, a DELC in one eye, a PK in the other eye. This is my patient. They look very similar, but look at the next slide. The right eye has a cell count of 1,500, 5 years out, and the left eye has a cell count of 400, about 6 years out. And you know, in a few years, that may not be the case. This was a 30-year-old patient. You can expect him to decompensate in the left eye during his lifetime and require repeat grafting. So something to keep in mind. Okay? Now what's important is when Professor Sarnicola asked me to join him on his paper in 2010, we did not know of the existence of the predecessor layer. So we thought we were bearing Descemet's membrane in many instances, or like you saw from the beautiful live surgery, at least getting down to 40, 50, 60, 70 microns. All of you know that because the keratocyte count is very low in the posterior stroma. If you get to that level, there's minimal interface haze, and the cornea is capable of much better vision, even though you leave it with a little bit of stroma posteriorly. Okay, so the disadvantages of DELC, and I hate to mention this too often, but the last bullet is poor reimbursement, at least in the United States. And when I say poor reimbursement, I don't mean just the actual reimbursement for the procedure. It pays less than an endothelial graft, but that's not the big issue. But really, it's the poor reimbursement per minute. Okay? And this is the pressure that all departments around the country feel at this time. And it's going to become a bigger issue. For example, last May, the chief medical officer came to see me and tell me that we can't have you spend the whole day operating with residents and fellows. The hospital loses money on a day like that, so you can do one teaching case per year, even though we are a major teaching hospital. Per day. One training case per day. So thank you, Carol. So it's a big dilemma. So 2013, Dua publishes his seminal paper. A lot of controversy in Europe, huge controversy in the United Kingdom. His fellows committed the eternal sin of naming a layer after a living person. So obviously we love Dr. Dua, we want him to stay alive, but that's the case. So we all agreed we will call it the pre-decimi layer. But that's the one that was, and to Bowman's, it's a condensated posterior stroma. But the most important thing about it, as you see here, is its bursting pressure is 500 to 700 millimeters of mercury. That's why with the case that Dr. Hahn presented, or was presented to him, that central desmatoceal, I truly believe, and especially if it's epithelialized, I don't believe these are desmatoceals if we define the desmatoceal as Decimes membrane plus epithelium. These are probably have a layer on top of them, probably the pre-decimi layer. That's why this young patient was doing very well for a long time. I think the presenter said she had 20/40 vision, and we see that frequently in melting corneas, that you're watching this corneal ulcer melt and melt and melt, and suddenly the patient comes in and tells you, I am seeing so much better. I'm so happy with my vision. Thank you, thank you, thank you. And the reason they're so happy with their vision, because they have no more cornea left. They've melted. So, but if they have the pre-decimi layer, it could save the cornea. So I won't go through this, because it's been covered so much. But big bubble type 1 is a big bubble that exists anterior to the pre-decimi layer, and big bubble type 2 is posterior to the pre-decimi layer. So what you're going to see here, and you've seen a lot of this, but this was the major indication for DALC in 2005, and I think still is in Europe, but not in the United States. So intaxoid segment being taken out, and you'll see the emphysematous wave, and as soon as the big bubble starts right now, you know it's a big bubble. You know that this is not just emphysema. So once you get to that point, you can do what we call the debulking of the cornea. Many of us like to put a little air bubble in the anterior chamber, which you will see shortly, and the pre-decimate bubble peripheralizes that bubble in the anterior chamber. Here we are removing the posterior stroma, and I thought I was looking at Decimes membrane for 5 to 8 years, but this is not Decimes membrane, this is a pre-decimi layer. Then you peel off the Decimes off the donor and graft it into position and suture it using your technique of choice. Most of what you saw this week was 16 interrupters, which is what most of us are doing now, but you can use the technique of your choice, right? So big bubble type 2, and I'll show just an example with the 80 seconds we have left. And when I had my first big bubble type 2, I did not know that what I was looking at, as many of you did not in the late 2000s. But the interesting thing about this, the bubble develops all the way to the limbus. There's minimal emphysema in the cornea, and I thought I was getting better at surgery. I said, oh my God, I am good, impressing the fellow. I was not good. I didn't know what I was looking at. Now, what you see what happens is many people will abort at this point and put the graft on. They will not take the posterior stroma off because it's not safe, because now we are truly on Decimes, rounded, scissors, touch Decimes, pop. It doesn't mean you have to abort, of course. You can still finish the case as a DALC because there's just a small defect in the cornea. If you have the luxury of a microscope assisted OCT, you can see exactly where your cannula is, and it could be very helpful in this procedure. So last year, Professor Fontana from Bologna, we put our cases together and we described the evolution of a big bubble DALC over the last 25 years. Thank you for your attention. I was so terrified to hear the bomb, I think it's a great idea, but it's pretty intimidating, as you know.
Thank you, thank you. Some comments, but no comments. The lecturer doesn't have any comments, I think.
Beautiful.
Yes.
Beautiful talking examples. In your experience, is there a particular cause or an etiology that is more successful than others in the outcome?
Thank you so much for the question. Thank you for the question. As I mentioned, kids do very well. So congenital disease does very, very well. Any disease in a child does great. And then I think it depends on, I don't think herpes does as well. It does work. There have been plenty of studies that show that it works. I think then it depends on the quality of the cornea and how, if you're treating the underlying condition. So I would say kids work best. I would say brain injuries. So when my neurosurgery colleagues send me a patient, I think those patients do very well. But the problem with neurotrophic keratopathy is there's so many reasons for it. And so if the underlying condition isn't being treated properly, then it's not going to last. And the major problem that I have is that patients get sent to me, and I will send them back, but I'm not sure who's monitoring the cornea because patients are coming from out of town. So I think that the most important thing is that an oculoplastic surgeon and a cornea specialist work together so that whatever the underlying condition is maintained and is treated, and oftentimes there's still something happening on that ocular surface which could negatively impact the durability of the technique.
Professor Vincenzo?
Well, thank you. Amazing talk. Just a suggestion, if you can give a suggestion to us. How do you treat patients after the surgery in order to maintain nerves in good health? Is it necessary to do anything? And the size of the nerves probably will interfere with the tear film distribution. Is this an issue, or do you treat in order to prevent any damage from this?
Yeah, so again, there's so many different reasons for neurotrophic keratopathy, and we're oftentimes, as was said, getting sent patients when they failed everything else. And one of my first 3 or 4 patients was sent to me for enucleation, and we said, okay, well, let's just try the neurotization first, because we have to do this on very severe patients and of all different etiologies. So again, working with the cornea team, oftentimes I'll do a torsorrhaphy at the time of the surgery. Sometimes I'll do an amniotic membrane graft at the time of the surgery. So there's a lot of things that we'll do depending on the status of the cornea to improve the success of the procedure, especially in the short term. We've also played around with nerve growth factor. So when we were first starting out, we were doing nerve growth factor around the time of the surgery, and I don't think that makes a lot of sense, because now that we've learned a little bit better about how long it takes for the nerves to grow, now I'm doing nerve growth factors at about 2 months after the surgery. And I don't know if it's working. A bunch of us are trying to pull our numbers together, but that's something that you can consider. There's a variety of things that have been published in the head and neck and other subspecialties about nerve growth. So like folic acid and other types of orals that you could consider. So there's a variety of things that we've tried, but since there's so many reasons for neurotrophic keratopathy and so many techniques, it's hard to compare what's really working, because all of the individual numbers are pretty small. As far as Delin formation, or as far as the nerves creating a problem with the ocular surface, yes, if you take a very bulky nerve and put it next to that cornea, you're going to cause some problems. So it's really important to dissect off all of that perineural tissue. And when you look at those fascicles, they're actually extremely small. And you don't have to get them, right up onto the limbus. You can actually leave them 2 millimeters away from the limbus, or when we work with our cornea colleagues, they'll do scleral tunnels so that they won't cause any, fullness or thickness of the limbus. So there's a lot of little tricks that we've learned to try to improve the success of the procedure.
Thank you. Dr. Claudia Corda, just to show us the final clinical case.
Good morning, everyone. So, I will present a case of a female patient who was referred to our cornea clinic for his corneal lesion. So, the patient had no history of ocular trauma or infection, and had already been evaluated at an ocular oncology center where malignancy was ruled out and was referred to us for a second opinion. So, slit lamp examination showed a white and vascularized corneal lesion with a lipid deposit on the pupillary margin. Despite of its location, the visual acuity is 1.0. So, anterior segment OCT showed a hyperreflected area with increased thickness corresponding to the lesion, and we decided to start the treatment with oral cyclovir and topical losartan. After 8 months of treatment, the lesion showed mild clearing, wide reduction of corneal vessels and corneal thickness. So, what do you think about this case? What do you think about our management?
Could you go back to the first OCT you showed? Not this one, the one before.
This one.
Yeah, so is the angle compromised there? The bottom left? Is that normal angle?
Yes, normal angle.
The patient have an iridocyclitis also at the time of the keratitis?
No.
So I was trying to escape to go to the restroom, but I was told I couldn't leave. So in this OCT, you see that the stroma is thickened there, and so when we're thinking about whether this is inflammatory or whether this is potentially neoplastic, because the epithelium is a little hyperreflective, that thickening in the stroma is not usually consistent with a neoplastic process. So let's keep going. More herpetic or something else.
So we see a lot of posterior and mid-stromal haze. Looks like chronic old lipid deposition at the anterior part of the lesion. So, there's some fine neovascularization. And corneal sensation, what's the corneal sensation, especially in this quadrant? Okay, so decreased corneal sensation, see fine neovascularization. We see lipid deposition at the anterior edges of the neovascularization. Any questions from the panel on the examination?
What is the question to the panel? Is it, what is this? Here you go.
Yeah, we reached a clinical suspicion of post-herpetic corneal opacity with neovascularization and lipid deposits. But the issue is that the lesion almost reached the visual axis, so currently she has a full vision. But our main concern is that if the lesion has even a very mild enlargement, her vision will drop.
Excellent.
So we are treating her with the oral antiviral and topical losartan in order to try to keep the lesion away from the visual axis. Do you suggest other treatments to, for example, hallow the regression of vessels that can lose lipids and can enlarge the lesion other than our treatment?
Excellent. So there's no mystery about the diagnosis. It's just the progression. Are you familiar with Dean Oana's work on mice, M-I-C-E? So this is something to consider in a case like this, especially after the first leakage, or as you saw the lipid deposition, and it seems to be very effective for this specific indication, where you canalize the vessels, inject a predetermined dose of mitomycin, and basically it's a chemo cauterization of the vessels to prevent a progressive phenomenon?
My opinion, not so easy, because there is not a permanent vessel just to treat with mice technique. What do you think?
At the presentation, vessels were very well visible. Now, under treatment, after months of treatment, vessels are partially regressing. So now they are less visible, and also cornea clarity is slightly improving.
Jane?
So, Ed, did the vessels go right up to the lipid now, or are they at a distance?
They kind of stopped just short of the lipid, but the previous photo showed the vessels. It was more vessels, more haze, less lipid. I think the lipid is chronic, so
it's really getting, so the whole thing is how do you stop the vessels from progressing or leaking more? And then there are a couple of things. It was a really old time, and I keep on referring to old time stuff, and that's not really good, is it? But there was an old time treatment Steve Foster at Mass Eye and Ear used to recommend, and it doesn't work all the time, but I've seen it work sometime, is using an argon laser, 1,000 milliwatts, 0.1 seconds, and first you laser every single artery, and then every single vein. And it's really hard to do. You can't focus on the vessel, you have to focus a little bit behind it, but then you'll see the vessel blanch. Sometimes it works, and sometimes it resorbs. The other, and the lipid can sometimes resorb. The other one is, what about injecting anti-VEGFs?
Can I just take this a different way though?
Yes.
So we're all concentrating on the vessels as the pathology. The pathology is retained viral particles. This is an immune stromal reaction. It's classic post-herpetic ISK. And the best treatment to prevent progression and actually to help rescarring is topical steroids. And so this is a patient who should be on oral antivirals forever. And I would hit her hard with steroids to maximize the regression of the scarring and the vessels. I would taper topical steroids, switch her to a load of prednisol, and I would never take her off topical steroids or antiviral because the next recurrence of her ISK would be in her central visual axis. So the vessels are in response to something. Getting rid of the vessels does not get rid of the stimulus of the vessels, which is retained viral particles from the herpetic disease.
Thank you. Thank
Has she been on steroids?
She used the steroids for, this follow-up is about 8 months from presentation. We used it for 6 months, and now she's continuing oral antiviral, plus we added the topical losartan.
So your first diagnosis is the correct.
So the reason why the lesion looks better is the steroids,
Yes.
not the losartan.
Yes.
And the reason why you could keep her from reacting is steroids. So, you talk to patients and they'll tell you the story. I came in and my doctor put me on oral antiviral, had steroids, and they slowly tapered steroids. Then I got red again, I lost vision, and be put back on top of the steroids. They tell you this happens 3 or 4 times, and the patient will say, why do they stop topical steroids? This is a patient because the lesion's so close to the visual axis, should never stop topical steroids because the recurrence rate is significant off steroids.
Thank you. So, thank you. I would like to thank my gorgeous panel, my perfect examiner, and why not the technical crew with SICSSO with the flawless service. Thank you. And I leave the podium to Professor Sarnicola for the post-op.
Good morning again. So let's see the results of the beautiful surgery of yesterday. First of all, surgery is not just the performance of excellent surgeons, and we have the privilege to host 2 excellent surgeons, Dr. Cheng and Dr. Basak, and you will see the beautiful result, but it's also a work of an entire team, nurses, anesthesiologists, residents, fellows who are here with the sitting collaborators. So it's a team work, and I think that the whole who contributed should be acknowledged. Thanks. So this is the eyes operated yesterday morning by Dr. Cheng. You can see this is the slit lamp pictures collected this morning. This is the donor eye in the inferior region. You can see that the eye is quite good. There is no particular congestion, no particular issues. Cornea is clear, and the conjunctiva has a normal appearance in the postoperative course. This is the superior region of the donor eye. You can see the area of the harvesting in the limbus, and you can see a good area also in the more peripheral side. This is the recipient eye. At the end of the surgery, a small tersography was done when the large diameter 20 millimeter bandage contact lens was put. So there is the contact lens on the top, but then we can see also the amniotic membrane well positioned, and everything is good for the cornea. We can see also the conjunctiva, and we can see the graft that has a beautiful appearance in the inferior and superior region. So this is, I think, a perfect possibility course, and for sure we will follow the patient, but surgery and early postoperative course was uneventful. This is the patient operated in the afternoon for a DMEC. Yesterday, the patient we dilated the pupil 1 hour after the surgery. We checked again the patient. He had a bubble covering about 70%, and there was already a level between the inferior margin of the pupil and the hair. So we did nothing. We did not remove the hair, and this is the amount of hair, about half percentage, that was in place today. We did nothing. Dr. Basak checked the patient personally and did nothing. IOP was good, evaluated manually, no other measurement on the eye, and this is the OCT. This is a video. You can see a perfect adhesion of the graft across all the scans of the OCT. So again, another perfect postoperative course, great surgery and great course. Okay, so we had perfect surgery, perfect postoperative course, and we are happy now to move to the next session, that is the award ceremony. Okay, so it's a pleasure for me to call Dr. Enrica Bonacci from the University of Verona, who won the best oral presentation. There is the prize of 1,000 euros. Yes, the price is 1,000 euro. I think that Professor Pedrotti, Enrica will invite us to a beautiful dinner with wines and etc., etc., etc. Thank you. Congratulations again, Enrica. Let's move to the Best Poster Award that it will be awarded to Costanza Rossi. Yes. There is also here a prize of 500 euros. Costanza is a postdoc at the University of Cagliari. Yes, for this prize, an aperitif dinner, standing dinner. Okay, so we move to the most original presentation, and the awards goes to second Ekisier Akar. She won 2 books of Carnegie.
Oh yeah, that's the one. Yeah, I wrote the chapter. That's something new. No, that's a.
And then most original poster, the award goes to Adam Cohen. Again, Adam doing the 2 books of the card. There are these people who were awarded of some prizes. There are also other colleagues who won the best paper of the session and best case report, and we will show the names in this slide. Okay, so Cohen, best case report. Back to the rescue in the factory OSSM. Next slide, please. A lot of base paper sessions. Innovation 1 goes to Dr. Sophie Dang on neurotrophic limb associated deficiency. The second prize to Dr. Eleonora Maurizi on endothelial cell degeneration. The third innovation prize to Dr. Gargariario del Barrio on intrasomal implantation in a rapid model. Prize number 4 to Dr. Hais Nur Koban on multimodal imaging. Prize number 5 to Dr. Nicolas Pereira, who talks about dog. And prize number 6 to Dr. Theofilos Tortas, who talked about cell therapy for endothelial reconstruction. There is also another prize that is related to the competition of microRec, correct? Okay, this is the device, and we will. Okay, and the prize goes to Dr. Angela Panico. Won the competition and will have the beautiful microRec device. A microRec connector for the leaf lamp and a microscope operator.
How many of you will come back next year?
How many will not?
I have to give a special thanks to Professor please come here. You don't know, but he followed the organization all the year, and every week speaking with my daughter about doing this. So he gave a great contribution. Thank you.
This is the best quarterly meeting in the world, no doubt about it. And Enzo's creation, idea, but really Enrica, Caterina, and Francesco, they do more work than you. You have to be honest.
Yes, they did 100% of the job. I just said, don't do this, don't do this, don't do this. That's it.
No, what a great meeting. Congratulations.
to give a special thank to my children. They very gently took me out. And they have done everything, and working on Saturday and Sunday, many times late in the evening, and I feel so proud of them. I want to thank all the friends that are coming here since many years, and they really are the best group that is the milestone where we are building the new building of SICSSO. But a special thank should go to Professor Sarnicola. We always have a local organizer, and the local organizer made a lot of job because it's coordination for the events and for the operating room and looking for the accommodation of all of you. And Professor Sarnicola was a great local organizer. Thanks.
Thanks. It has been a privilege to have you here in our city. We had a beautiful talk in our university room on Wednesday evening with the most important speakers on the cornea, teaching at the students, residents and fellows. It was a very privilege. Then a surgical session for the operating room, and then live surgery on our outpatient. So it was a very privilege to be here with you, sharing our facilities, our patients, our knowledge, and but more importantly, learning a lot from all your teachings and insights. So thank you to Vincenzo for sure, and also Caterina, Enrica, but Francesco, where is Francesco? He is almost in the back of the room, but I think he deserves a big applause because I want to him all times of the day, all the days in the weekend, and he was so kind and very always available for any issue. So thanks, Francesco.
And a special thank to all the speakers, and especially to the medal lectures. But believe me, without our staff, the meeting is not possible. So please come here. Martina, Sara, Davide, ecco, Simone, Francesco, everybody here, Sara, so now you know who is Sara. So, thank you so much to this strong staff. Where is Simone? Simone? What? On the computer. Okay. Well, Simone is a good guy. He works for us since ever. And I just want to say something. Okay. So, and thank you so much. Let's meet again next year.
You know what I have? I have handouts. It's here. They come in.
Oh, nice meeting you. Thank you so much for everything. Muchísimas muchísimas gracias. You were amazing organizing and everything. Thank you, no thanks to you.
Ah, Sara, voglio fare la foto.
No,
Caterina. Dai, ma Chiara. Voglio fare la foto.
Scusate. Ale.
Cosa? Voglio fare la foto.
Ancora.
We're tomorrow. Good seeing you. Thanks. Safe travels too.
So maybe we'll see you on the beach.
Probably. I just want to say congratulations to Vincenzo.
Congratulations.
Thank you. I was not expecting it.
Oh, that's great.
I was at the back minding my business.
Yeah, that's fantastic. And now you have a little extra cash. That's great. Thank you so much for all your help.
Thank you.
Yeah.
It was a privilege.
Yep.
Come on, baby.
And thank you so much for the pictures and all your hard work.
Monday or tomorrow, I send you inews24.eu.
Perfetto.
Okay.
Perfetto.
Okay.
But you have my name?
No, Sarnicola. Dai, ok. Ciao, grazie.
Grazie Caterina.
Sicuro.
Vale, ciao, grazie mille. Figurati.
Dai, send dai.
Sandra.
No, levati, che
No,
non c'è
la
più spazio. Levati.
Scusate,